So inshallah, we'll make the recordings possible. Once the webinar is finished, it will take us a couple of days to sort of clean up and sort out, and then we'll make it available to you with the link. Very, very important. All of you that are in this chat, all we are seeing are your login details. We don't have your full name or your profession. So if you don't have your proper name as a login on this webinar meeting, you need to contact Sister Kashifa, message her or email her with your full details so that when we make out the CPD certificate, we'll be able to give the correct details. Regarding the CPDs, the good news is we've been accredited for 2 CPD points for clinical and 1 ethics. Ethics points are a bit hard to come by. For those of you that are asking why it's such a small amount, the CPD accreditation has been reviewed. So for every hour you get 1 clinical point, whether you have a questionnaire or not. So basically this session is going to run from 10 o'clock to 1 o'clock. It's 3 hours of your Sunday. And we'd like to thank you all for joining us. Inshallah, we'll be having a very, very informative discussion. As far as questions are concerned, I think in the interest of time and in the interest of having a more integrated discussion, we will try and collate all the questions in the chat box and have it as a panel discussion once all 3 speakers have spoken. Regarding your questions, keep things civil. Try and avoid repetitive questions. We will try and, if we miss any of you, please just let us know, but we'll try and get through all the questions, time permitting. For those of you that are wondering about IMASA, I mean, a lot of us have been IMASA members, which means we get a calendar once a year. I'm sure you saw the advert before we started, but IMASA has been in existence for 40 years. And we really, across all spectrums of society, a lot of the guidelines we saw coming out over the last few months is our first interaction with the Islamic Medical Association. But as far as IMASA is concerned, we've been around for many years, running clinics, projects, guidelines, member conventions, screening programs. There's a whole list of it. If you want more information about IMASA, then feel free to go to our website. It's on www.imasa.sa. Sister Kashifa will post it .org.za. So once again, let's just go through the housekeeping rules. Remember to mute, put your video off, and ask your questions in the chat. As far as breaks are concerned, we're not going to police you, so you're allowed to take breaks. We will try and not stop for breaks. We will try and continue the program continuously. It's just going to make life easier, and we're going to be able to get through this faster. We will start now with our first speaker, Dr. Fatima Lambert. For those of you who don't know Dr. Fatima Lambert, she's a colleague. She's an anesthesiologist in private practice. She's an intensivist. She did an undergraduate and postgraduate program at the University of Witwatersrand. She's just completed her fellowship in intensive care, and she's currently working in private practice. But alhamdulillah, Fatima has been very involved and is very passionate about helping the community, especially during this COVID time. Many of you have seen her on a lot of other webinars. A lot of our guidelines we are basing, especially in the broader Indian, the broader Muslim community, have been based on a lot of input from Dr. Fatima. So she's had quite a bit of experience, both in drawing up guidelines, in personally treating COVID-19 patients, and also in helping the private hospitals, public hospitals, and practitioners treat these patients. So she's done a lot of she knows a lot of the current controversies surrounding these things that are concerned. So I'm going to hand you over now to Dr. Fatima Lambert, so she can give us some insight into her talk. Fatima.
Assalamu alaikum everyone. Jazakallah Zahir for the introduction. I'm very humbled. I'm just going to share my PowerPoint presentation. Okay, can everyone see it? Zahir, can you see it?
Hi, it's coming through nice and clear, Fatima. Jazakallah.
Okay. All right, so we found ourselves in a very difficult time. I don't think anyone would have thought that we would have found ourselves in this time where we might be looking at home, and these patients, besides all these initiatives where we're getting oxygen concentrators, it's more than that. It's it's like an ICU-based type of situation. And I thought I'd give this talk so to help and assist everyone to be able to do this, especially if you're not experienced. So Dr. Zahir gave a very nice introduction, and I'm very humble. So let's get to the crux of it, right? So this is my contents, and if everyone can remember, when you go into ICU, there's a mnemonic. It's fast hug. So I thought I'd make a mnemonic for home-based ICU. So it's LV, fast, lay, go. Okay, so it stands for location, ventilation, fluids and feeds, analgesia, steroids, thromboprophylaxis, lung exercises, antibiotics, glucose control, other management, and bloods. So this is the mnemonic everyone can use at home, and it can be easier for you to follow up your patients every day. So let's see, what is the current situation? We know there's a rising number of infections. Last night was about almost hit 13,500 new infections, and that's only what we know, because we know that we don't we don't test the family members. Many people are not testing and just isolating. So that's the numbers that we know. Our hospital capacity, we already have a stressed healthcare system. We know. We've worked in public, we've worked in private, we've already had a stressed healthcare system. That is why we are so worried about the NHI and that, because we know how our healthcare system is. Our hospital capacity cannot cope with the number of people that are in our country. With the TB, with HIV, I don't even know what's happening to those patients, because with COVID, what happened was an already existing hospital, which had beds for the amount of patients in the country, is now dividing that beds for COVID. So there's no new beds, despite what's being said. It's just the already existing beds that are being divided for COVID. So our healthcare system is stressed. But lo and behold, our government has a plan. And this is what they said in the week. Mass grave sites prepared in Gauteng. That's the plan. So obviously we as a community have to step up, because we don't want mass grave sites. We would have wanted a massive hospital, but if they cannot give us that, then fine. We are going to step up as a community, because inshallah we can be able to save more lives. Okay, so the first thing I thought we'd do is discuss is it's a multidisciplinary approach, and you have to have a network. No one can do this alone. So the first people on board is going to be the GPs and the specialists. So the GPs and specialists must network and be together, and I'm sure in many areas this is already happening. The emergency medical services, so I put Sabri Chisti and this Pulsatia, they're the ones that help us, and they're the ones that can be involved in telling us is their hospital bed, what's their hospital capacity. So they're very organized in terms of that. They help us with putting IV lines. They help us with donning and doffing when we want to go to homes. So we must have them in our network. Physiotherapists are very important, and if we can get a physiotherapist that can go to the homes, obviously not every day, but at least a few times a day, or do video calls with the patients. In ICU, I've seen the physiotherapist is the #1 person that is helping these patients, especially with the exercises, proning, all of that. It makes a big difference. And of course, the family and the community. So the family is very important, because they are the ones that are going to they need to help this patient, need to take vitals. Sometimes these patients can do it for themselves, but sometimes they are so weak, so dehydrated, so sick that they need someone, their family member, to assist them. So for them also, when we're looking at these groups for donations with oxygen concentrators, don't forget that we might need PPE for ourselves, but some PPE for them as well. And then in Lenasia, we also have another team, and I hope everyone else can get this on board in their community, where there's a delivery service. It's pharmacies, groceries, chicken or meat products, all necessities, where if a patient doesn't have someone from outside and their whole family is isolating, then all they have to do is contact a person, and that person will be able to see what necessities they have, and they have for each necessity they have a delivery system. So as you can see, COVID is a very different disease. We're in a very different era of a disease, and that is why this is very important. Multidisciplinary approach and networking and working together and being united is very, very important when it comes to this disease. Okay, so where are we going to have this home-based ICU? It's at home, and why? Because patients have tried to look for an ICU bed. The hospital is full, there's no beds. And at each point where you assess the patient, and if you feel the patient's getting worse, you for consent. Sorry, I think am I back on?
Yes, doctor, you're back on. You broke up for a few seconds at the home-based part.
Okay. So, so consent is very important, and there must be a disclaimer, and patients must know that consent must be given by them, because what we're doing at home we cannot do optimally like we can do in hospitals, because we're not going to take bloods every day. We're not going to take be able to do physio every day. So they have to opt in, and they have to know this difficult process. But what we're also seeing here in Lenasia is that people are very, very scared to go to hospitals because of the stories where they go to hospital, the family cannot see them, and then they come out and they're already going to their cupboard. So that's why we were also seeing this, and many patients are trying not to get into hospital, but it also has medical legal implications. So you must try and convince them first to try and get into hospital. If they don't, then make a consent form for refuse hospital treatment care, but try and help them at home. Okay. You must remember, when you go to the house, there's increased risk. There's PPE guidelines that's on the IMA, where there's guidelines for equipment. There is PPE guidelines there, and it's explained what to do when you go to the house. But if you have the emergency medical services, they're very well trained, and they will be able to help you. And then I just do a little bit about when do I visit the patient. So for the consent and disclaimer, I've adapted it from the Critical Care Society of South Africa consent forms. If anyone wants those forms, I can give it out. And they have it very well organized and structured, but you just have to adapt it for the home base. Okay. So this is, I just wanted to go up to delve a little bit into the PPE guidelines. So remember, your cell phones, your jewelry, everything needs to be sitting in the car. Nothing must come out. Then remember your car keys. Where are you going to put your car keys? So you can either put it inside your scrub pocket, which is going to be your third layer under, or you can put it nearby a pot plant or something, hiding just outside the house. But remember, this is South Africa, so try and hide it nicely. I suggest that if you guys going to do home visits, get the 3M mask. It's I bought it for about 1,800 nights, going for 2,200 with 12 filters, and it's better because it gives you 99% protection. The FFP2 gives you 94% protection. The N95 gives you 95% protection. But why I'm saying the 3M mask is because when you're when you're going to home visit, it's a very different space. It's a so it's much it will give you more you will be more at ease if you have the 3M mask. Hazmat suits. So in hospital, I don't use a hazmat suit. I use a gown in that. But when you go to the home, I said it's an increased risk. So it's better to use a hazmat suit rather than a gown. 2 gloves, hats, visors, and 2 shoes. Then I put these packets here because you guys will see I don't want to speak too much about it, but there is guidelines in the IMASA equipment guidelines where you put 3 packets outside. 1 will be for doffing off. The other 2 will be for your visor and your shield because you're going to reuse it. So you put that in the 1 packet, you sanitize between, you put it in the other packet, so they double packeted. And the 1 waste where you have your gloves and your all the disposables, that you can tell the family members that they can keep it there for like 4 days and then they can dispose of it after 4 days in the main bin. But it's explained very well in the guidelines that I'm sure all of you have. So when do I visit the patient? So obviously the first consult. So either they'll come at your guys' surgery, and you can either visit them. You can with your full PPE see them at the car, or you can maybe they're too sick to come to the surgery and you'll have to go home. If they're moderately to severely dehydrated and there's no beds in hospital, so you're going to assess again and see if there's beds in hospital. If there isn't, then they might need an IV line. The emergency services also come in handy here, where they don't mind to put the IV line. And I'll explain that in details later. If we're giving advanced ventilations, because now what happened is we weren't getting beds for a couple of patients, and we were lucky enough to get CPAP. So CPAP, I'll explain a little bit more further down. So we had to give these patients CPAP, and then for that we have to go in to set up the CPAP and show them how it works so we can go down or up on the pressures. And video calls for follow-ups. So that works very well. So the first thing is we're going to assess the patient. So you get mild, moderate, and severe patients. So the mild patients is symptomatic treatment and symptom follow-up. I know there's a lot of herbal medications. There's a lot of other things that are being used, but mild patients usually get better on own. And as long as you have the pulse oximeter in every house that has coronavirus, you will be able to pick up the patients who become moderate or severe. The first thing you try and look for is a hospital bed first. Even if the patient refuses, try and look for a hospital bed first. If the patient plain bluntly refuses, get that consent to him and say that if anything happens, you are not liable, but you will try and help them to the best of your ability, because I don't think any of us have that human heart not to help them if they don't want to go hospital. Okay, so here's a table I made for moderate to and severe. With the NICD guidelines, I don't completely agree with them in terms of the sets and heart rate. So this is what I have made. So the moderate patients, the mental status will be GCS 15-15. The severe patients, once the patient starts getting confused, it does mean they're getting severe, or they might be hypoxic. So you might need to give them a little bit of oxygen, 2 liters per minute to 4 liters per minute, depends how what sets they are at, and their GCS may improve. The other thing that can decrease the GCS in these patients are if they dehydrated, and they become so severely dehydrated that their renal function gets deranged and their sodiums go up. So in that cases, if the hypoxia doesn't help, we must look for other causes. We must look for other neurological complications of COVID, such as they can get an encephalitis, viral encephalitis. And we know in Italy, they said 5% was associated with stroke. In fact, the very first patient we had here only presented with stroke. 65-year-old, healthy, no comorbidities, only presented with stroke. And even in the hospital, she had an echo, she had nothing was found. Her blood pressures were normal, her ECG was normal, so they can get a stroke. So assess the neurology very well. SETS, moderate is 85 to 92%, severe will be less than 85%, respiratory rate less than 25 and greater than 25. And let me just bring in here about the happy hypoxics. So they're the ones that will be speaking to you. The GCS will be normal, the respiratory rate will be 16, but the SETS will be 50%. And that is why it's important that a SETS monitor or pulse oximeter must be in every patient. There's a couple of patients I've seen in the ward where the physicians would call me and then I'd go in the ward. And if I didn't have the SETS monitor, I would be like, why are they calling me for this patient? And the minute I put the SETS monitor on, that SETS is 50%. So that's very important to mention. The heart rate on the NICD guidelines, the heart rate is more than 120. But for a patient to get to that heart rate means that they're working very, very, very hard. So I drop the heart rate. I say moderate is 100 to 110 and severe is greater than 110. And most likely in most patients, it's either they're having a fever or increased temperatures that's increasing their heart rate, or they're having, or they are dehydrated and probably need to increase intake. So for hydration, especially when you're doing a video consult, how easy is it to assess hydration? It's not. You can tell them to pull out their tongue, but sometimes the video consult is, maybe you don't have fiber at home, who knows? Maybe they don't have fiber at home, so you won't be able to see the video properly. So capillary refill time is important, and I'm going to show you guys a video later on capillary refill time. So moderate will be 2 to 3 seconds, normal is less than 2 seconds, and severe is more than 3 seconds. Temperature, I've said moderate less than 38 and severe 38 to 39, but or greater than 38, but the mild patients can have a high temperature, and then we'll just have to treat that with anti-inflammatories and antipyretics. I'll go into it a bit later. And then blood pressure. So in these patients, they don't have the typical sepsis, septic shock where they get hemodynamically unstable unless there is a secondary bacterial infection. If it's just COVID alone, I haven't seen them having hemodynamic instability. However, we need to assess this. So in the kit of when we're doing the oxygen concentrators, in the kit, we can maybe have an oxygen concentrator, a pulse oximeter, a temperature probe, and a blood pressure machine. And then you can see which patients require the blood pressure machines, which patients do not. And if they do not have a blood pressure machine, that might be the other time in which you see their hydration status dropping or their mental status dropping, and you might need to go assess them for to check their blood pressure as well. So ventilation, home-based ventilation. I'm sure you guys as GPs are sitting there and you're like, sure, for me it might be easy, for Dr. Isup it might be easy, for anesthetists, for physicians, for intensive it might be a bit more easier, but for you guys it might be out of your depths because maybe you guys forgot. But inshallah, after this presentation, you guys will be a little bit more comfortable. So we can give oxygen via an oxygen concentrator, and I will explain to you about it just now, via nasal prongs. These are the delivery system. Face masks or polymasks, or as they say internationally, non-rebreather masks, or continuous positive airway pressure. And the other one that they are selling is the BiPAP, bi-level positive airway pressure. So these are the oxygen concentrators, and someone just asked me to briefly go through this here, because on the market now, remember what the masks, how from 2 Rand, the masks went to 60 Rand or 80 Rand per mask. So this is what's going to happen with the oxygen concentrators. We were lucky that we did get oxygen concentrators before the lockdown. and we got it a little bit cheaper, but now I see they're very expensive. And then there's oxygen concentrators that are on the market that do not contain pure oxygen. So I just wanted to go into a bit of this. So what it does, it entrains room air. It is a pressurized system. It is a compressor. So it compresses the air, right, to take out to separate the oxygen from the nitrogen, push the nitrogen through one port, and get concentrated oxygen into the main delivery system. So that's how it works. And these ones here are the roller ones. I call them the roller ones. And it's not the tabletop ones. Why? I like the roller ones because when they concentrate the oxygen, it gives you 85 to 95% of the concentrated oxygen. So when you run them at 2 liters per minute, and I have another slide to give you the percentage when you're running them at certain liters per minute, you'll be able to get a better oxygen concentration than the others, right? The tabletops oxygen concentration, I'm very worried about their purity. So they call it the oxygen purity or the oxygen concentrators. It's less inside there. I'm not sure how less, but in one tabletop concentrator at 7 liters per minute, the outflow of the oxygen was only 36%. And that's very low. I'll show you the percentages just now. There's a WHO document guideline on concentrators. Just Google WHO guidelines on oxygen concentrators. And in there, it will show you how the concentrator works, and it will show you the actual specifications of the concentrator. Okay, so nasal prongs, right? So it's very difficult to make set protocols, but approximately if patient sets are less than 92% and you see they're healthy, they're well, then try lung exercises first. And I've noticed that proning position especially does help. I'll go into it later, but it does help. It improves the sets, and usually they don't need an oxygen concentrator. But if it does not improve, then you need to set up the oxygen concentrator. Your nasal prongs usually go 2 liters up to 4 liters per minute, but we can push it up to 6 liters per minute, right? And if you get the sets more than 92%, then that's okay. I'm going to tell you guys about the obese and the COPD patients. And every time it must be with proning plus minus lung exercises. And the physio will tell you how important that is. So these are the nasal prongs liters. So you can see at 1 liter per minute, it varies 24% to 28%. So 2 liters is 28%, 3 liters is 32%, 4 liters is 36%, 5 liters is 40%. So that's already going on a Venturi mask, and 6 liters is 44%. So you can try and up it if your oxygen concentrator can go to 6 or 7 liters. Most of the oxygen concentrators are 5 liters per minute unless you're buying a 10-liter oxygen concentrator. But it looks like the 5 liters are working if you can get them early. The thing about this is when you have 100% oxygen purity, or say 98%, because you can never get 100% oxygen purity in the system to get out of there. So that is why I'm so I'm stressing about that oxygen purity inside the concentrator. So face masks, and these are Venturi masks. If the sets do not improve, then we need to put a face mask on, and it comes in 40% or 60%, and they need to be running at least 8 liters per minute. So for these, we need a 10-liter oxygen concentrator, right? I have a picture here. So this is the Venturi mask, and if you can see, I'm going to show you with my mouse. You have up until this point. So even though they're saying 8 liters per minute here, if you give a nasal prong at 4 liters per minute, you can get that oxygen concentrate in 35%, and the nasal prong is much more comfortable. The problem when we go to 5 and 6 liters with a nasal prong, it's very uncomfortable for the patient because the oxygen damages the nasal hairs in there. So that is why if you do want to go to 5 and 6, and if you have the option of having a 10-liter with a Venturi mask, then maybe if you are going up to that, then rather use a Venturi mask. Okay. So non-rebreather masks. Do you know if I'm in ICU and if my registrar had to use a non-rebreather mask in a patient, I would have blown my rockers. I would have said, no, 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 you cannot use a non-rebreather mask. But COVID, as I said, we're living in a very different era. And if we have no other option, then it has been shown that non-rebreather masks with the patient prone has been able to, I'll tell you, they meet the oxygen demands in these COVID patients. So at home, we may not have an option of giving them a CPAP or high flow nasal cannula. In hospital, if they need a non-rebreather, I try my best. But even in hospital, we suffer and getting a high flow or a nasal cannula or the a non-invasive mask, then I do use a non-rebreather with them prone. The problem with non-rebreather is they need a high flow. 10 liters per minute should be okay. That would give you about 86 to 90% of oxygen, but 15 liters per minute would give like 96% of oxygen. But unfortunately, at home, we're not going to have that option. So I just have a picture of the non-rebreather mask. So that's, we in South Africa commonly call it the poly masks. And that's the reservoir bag, which fills, gets filled with oxygen. So let's go on to CPAP. So CPAP is continuous positive airway pressure. It's used for obstructive sleep apnea. I'm going to show you a picture just now. It uses room air, okay? If you get a BiPAP, so there are BiPAPs on the market. So CPAPs are usually going for around 15,000. BiPAPs are usually going, I know some are going for 40,000, but please do not be fooled. Make sure they give you guys a demo, because some of them say that the oxygen can be put on the mask and I've noticed that it cannot. So if they are quoting you more than 15,000, make sure that this BiPAP must be able to connect to an oxygen concentrator either at the back or on the mask, right? And a BiPAP is a bit better because you can connect to the oxygen concentrator. However, it requires a minimum of 10 liters. In hospital, we even use more, 15 to 25 liters, but we're trying our best and we're trying in our limited resources, limited capacity to try and help the patients. And I'll tell you a bit of my experience of other patients, if I can get my next point. Yeah. So what happened was we had so there's already 3 patients here in Lenasia that are already on CPAP. And we had no option because we had no beds. We tried every single day for a bed. The hospitals were full. So what we tried to do, modified and tried to put the CPAP over the nasal cannula. And I'll show you how it must be a nice tight fit. And shukar alhamdulillah, it did work. We went a little bit higher on the pressure, and that is why you guys need to network with specialists who know about CPAPs and BiPAPs and ventilation. And they'll be able to guide you guys in terms of what pressures to use, what tidal volume. So the CPAPs we have, you can set a pressure support, a PEEP, and a tidal volume. And it actually works. And alhamdulillah, the one patient is actually off the CPAP. We can actually sterilize that one and use it for another patient. And he's on his way to recovery. And the other 2 we've just started. So inshallah, with our efforts, and if you guys can also get on board, we can save more patients instead of increasing the grave sites. Okay, so consult with the specialists and anesthesiologists, intensivists, physicians. They all, especially anesthetists, they're very good with ventilation. So if you have them on board, it will be good. So this is the CPAP machine. So it can come like that, or it can come like an elongated machine. This mask for this patient here is very small, if you can see. It should be going down onto the chin. So that's very important. Our CPAP does come with one mask, but it looks like it's an average size mask. But that's also very important that it must be a nice tight fit. Okay, so two patients that we need to worry about is the increased BMI patients, so the ones over 30, and the ones with COPD. So why I'm mentioning these two is because the increased BMI patient or the obese patient can have either obesity hypoventilation syndrome or obstructive sleep apnea. That's a spectrum. Okay, or in the COPD patient, they can have a normal hypoxic drive. So these patients may be used to the hypoxic drive, and their sets may be 88%. And maybe we won't even know if these patient sets are, we don't know the baseline sets of any patients. So if you find that a patient is obese or has COPD, try and keep their sets 88 to 92% rather than pushing them too high, because you can decrease their hypoxic drive and they can stop breathing. So that's very important. Okay, so I put this at the end of this part because people are very worried about aerosolization. So this was a study done in Washington, and what they did is they had a mannequin, and they put smoke inside for it to come out through the for the mannequin to exhale. And they found that with high flow, because what was happening is everyone was getting intubated, ventilated. At that time, 100% of patients who were getting intubated, ventilated patients died, right? At that time. Now, people said, no, we must use non-invasive. So that was in Washington. And in Wuhan, they were using the non-invasives. So because people were so worried about aerosol generation. So if you can see with high flow nasal cannulas, the maximum distance is 17.2%. The one that's the most is a Venturi Mask at 40%, and that goes just a ruler and 10 centimeters, so about 40 centimeters. So it's not too terrible, the aerosol generation on these delivery systems. So the take-home message is, earlier we start on the patient on oxygen and lung exercises, the more effective the intervention. So our next, so we did location, ventilation, now we're going to do feeding of fluids. So patients get dehydrated. You must remember they're very sick, so they don't feel like eating. Lots of them lose their appetite. They don't feel like drinking. They just want to lie down. They're feverish. They're losing water everywhere. They're sweating. They're not increasing that intake to match their fever and sweating and loss of fluids via those pathways. So that is why we have to be on top of them all the time in terms of this. And we must stress to the family, drink at least 1 to 1.5 liters of water a day at intervals. And they'll say, yeah, they drink a whole lot of stuff. So you try and give them. Sometimes I actually tell them, so for this patient, every hour you are going to give them 100 mils per hour. So can you see, I'm trying to get that ICU based model that I use in hospital, trying to get it into our house. So it's quite difficult, but I think it does work, right? So you say 100 mils every hour, or you say 200 mils every 2 hours, if it makes it easier for them. So try to give them a guide instead of just saying 6 to 8 glasses of water a day. Because when you say 6 to 8 glasses of water a day, it can be a 40 ml glass. So it can be at least with 100 mils, you have that guide, and they will not be pushed into kidney dysfunction or acute kidney injury. Rehydration solution is very good. So either the Rehydrate, where you mix it in 1 liter, and this I got from my sister, and she uses it a lot. So that rehydration solution is good, and that you only need 1 liter, and it has all the electrolytes that we need. The only electrolyte is missing is the potassium, but you can put some orange juice, like 2 glasses of orange juice in it to get the potassium. Ensure Frezubin shakes, which you can get from the pharmacy. If the patient's not eating, it's okay as long as they're rehydrating themselves, but then get for them, tell the family to get for them Ensure or Frezubin shakes, and that is easier for them to sup and take in. remember, the renal patient and the cardiac patient, they may need fluid restriction. So remember, if you have a renal or cardiac patient, ideally in hospital, but if you don't, if you can't get them into hospital, then consult with a specialist, Dr. Wadi. He can tell you what to do, and then you can give them fluids according to that. So my next slide is going to be a video of capillary refill time.
For the capillary refill test, apply pressure to the distal volar portion of the digit until the tissue turns pale. Once the tissues turn pale, simply release and count the number of seconds it takes for the color to return to normal. One more time. A negative result or a normal result is when color returns to normal in 2 seconds or less. This was a negative or normal result. A positive result would be if it takes more than 2 seconds for color to return to normal after the pressure is released. If your client has a positive result, vascular status is impaired and healing will take longer. You will want to avoid thermal modalities and avoid compression techniques for edema.
Did you guys see the video? Huzaifa?
No, Fatima, the video didn't play. We just heard the sound.
But you heard the sound. How? Oh, maybe because I need to put my video on.
For color to return.
I'll just put the one. Can you see it
One more
now?
time.
Can you see it now?
Yes, now we can see the screen.
Okay, let me just show
To return to normal.
Maybe just replay it here.
One more time. For the capillary refill test, apply pressure to the distal
No, doctor, it's gone off again.
until the tissue turns pale. Once the tissues turn to pale, simply release and count the number.
Is it gone off, Huzaifa?
We can hear the sound, but we can't see a picture. So at the
Fatima,
bottom,
we can
show the
show
sound.
video, maybe show us on your own finger.
What you say?
Dr. Shoaib says maybe you should show us on your own finger.
Okay, let me show you on my own. I'll let him speak and then I'll show you on my own.
To normal. One more time. A negative result or a normal result is when color returns to normal in 2 seconds or less. This was a negative or normal result.
Okay.
A positive result would be
Okay,
if it
now I
takes
have to
more
get
than
out
2
of
seconds
here.
for color to return to normal.
I always struggle to get out of here. Okay, there we go. Okay, so the next one is feeds and fluids and now analgesia. These patients complain of headaches and body aches, and it's so severe. Your heart actually goes to them. So you either can use paracetamol alone, but a lot of them say that paracetamol is not working. So you can use combinations with either codeine or Brufen, or I forgot to put in mefenamic acid or Ponston. Brufen I don't like, and Dr. Wadi will be happy that I'm saying this, because all these non-steroidals, we've seen renal failure and GIT bleeds and GIT side effects. So that is why I don't like Brufen personally.
Sorry, Dr. It's Huzaifa here. I see on the chat coming through that the slides are not up. I think the slides stopped sharing.
The slides stop sharing. Okay, I can do that again. Share. Wait 1 minute. Just give me a minute. Okay, it is on. Let's see. Can you guys see?
Yes, it's back up. Perfect.
It's better? Okay, perfect. Okay. Okay, but so you guys never see my bouncy. Okay, the actual brain and the panado were bouncing there. So as I said, they have a lot of pain, and I don't like Brufen. So the Brufen controversy came where there was a French study of 4 patients, or not even a study. it was just an observation from these people, where there was an observation where the brufen, because theoretically might affect the renin, angiotensin, aldosterone system, and we know that SARS attaches to the ACE2. So theoretically, they were saying no, brufen might increase inflammation. They should have just left it at that, because if you don't use brufen, it's better. But it's actually not a thing, and you can. I wouldn't use it. Let me just see. Okay, so important now. So we went through location, ventilation, feeds, fluids, analgesia. Now we come into the S part, and that is steroids. And that is why I need to tell you guys about the phases of the virus, because I've been hearing a lot of people, as soon as this recovery trial came on, the recovery trial came, steroids, but no one read the recovery trial. No one read when was the steroids given. And people have been giving steroids in packets, or I've heard that pharmacists have been giving steroids to patients with coronavirus. I've personally experienced patients who've had, who are healthy, had steroids in the beginning, and the inflammatory response worsened. And why this could be is because steroids decrease the immune response. It has so many of other side effects. Now you get a secondary infection because of the steroids. So giving it at the inappropriate time will worsen the coronavirus. Okay, so this is the phases of the coronavirus. So it's in 3 phases. Stage 1 is the early infection. Stage 2 is the pulmonary phase. And so stage 2A is the pulmonary phase. Stage 2B is the hyperinflammation phase. So initially, when it just came in before even the recovery trial, we were already using it here. So I used to look at CRPs. Then I used to look at ferritins, and I used to use it here. But then Prof. Richards said that we can start using it in the pulmonary phase, and I'll show you the study that it's not specifically to COVID, but it's specifically to ARDS, and we knew this from before, that we can start using it in the pulmonary phase. So that is why I say steroids must not be given by a GP. It must be given in consultation with the specialist, because to get that pulmonary phase clinically is very difficult. As I said, patients can have sets of 86%, and you tell them to prone, and they okay. It doesn't mean they're in the pulmonary phase. There's my niece, I know, she had sets of 88% throughout the stuff, and then she was fine. We just monitored her. So it's important to be with to consult with the specialist when giving steroids, and even medical legally consult with the specialist when giving steroids, because otherwise you can be sued, because it's a drug that's not 100% for COVID. Let me go to the next one. So as I said, must be with a physician or intensivist dealing with COVID. So what WHO did, they inferred from studies. So we know in bacterial pneumonias, the first thing we do is give steroids for 3 days. We give azithromycin for 3 days, because that has been shown to work. From viral pneumonias, we knew that that's not working, even in the influenza virus. But they were low quality studies. And what COVID looks like, COVID looks like it's giving that like ARDS type of picture. So we started using the steroids in the mnemonic phase, and you can see the studies after that used in intubated patients in the inflammatory phase. I'll show you some of the studies. And as I said, we have to individualize a patient. So when you network the GP in the specialist, it's so nice how it works here in Lenasia, where we're networking, and we're able to, and even now the GPs phone me now and say, my patient is this, my patient that, I'm not giving steroids now, okay, I'm going to do this, and I'll be like, no problem. So they're getting the hang of it, but they do come past me just so that they are covered as well. And oh yeah, it's very difficult to give protocols for steroid because GPs were in the beginning they were saying, what day must I give it? What day must I give it? I don't know what day. No one knows what day we must give it. We need to individualize the patient, and that's why I rather phone a specialist. And as I said, the mild cases, if it's initiated too early, it may decrease the immune system. Remember the side effects for steroids? I'm using a higher dose than the recovery trial, and I'll show you the different studies, but it is less than 14 days, so it's a shorter duration, so we're not getting the side effects. The only one that I'm seeing is the GIT side effects, so we might need to give a proton pump inhibitor with the steroid, so please watch that. Okay, so these were the studies. These were like in early February, where 2 showed it didn't show any medical benefit. 1 showed greater risk of ICU admission. But when I was reading those studies, it was actually not looking at steroids and looking at the control. Those studies took patients, they were just showing clinical characteristics of patients, and they were showing what the patients are on. And then they just plugged in 26, like I think Liu et al. Plugged in 26 were in ICU, 36 were in ICU, 26 were here. They didn't compare. Is it because of the glucocorticoid that they went to ICU? Is it because the inflammatory response? They just inferred, and it was more objective results. Then Wu et al. They had a proper controlled study. It was a very low study, but you know, now in the pandemic, we're going to get very small studies, and they found there's a reduced risk of death with methylprednisolone. And then Ling et al. They said that the virus might stay in the corticosteroid group longer, but they're also very objective studies. So it's very difficult to interpret studies in today's times. Okay, so this is the big study that I follow, right? This is not specifically to coronavirus. It's specifically to acute respiratory distress syndrome and dexamethasone in acute respiratory distress syndrome. This was done in 2018 in Spain. What they did, they gave the patients 10 milligrams PD, so 20 milligrams a day for 5 days, and then 10 milligrams a day for 5 days. So at home, I'm halving the dose. I equated the prednisone and I'm halving the dose, and it looks like sugar, it's working. In hospital, I give the full dose, 10 BD, and then I drop to 5 BD. So I'm following their protocol. And inshallah, I'm going to try and get case series out in it, and let's see how it works. And so far, alhamdulillah, it's working, but let's see what happens once I get the case series and that out. So this is the summary of the recovery trial. I had to put it on because it's better than before, because now not 100% of patients are dying, but the number needed to treat is quite high. So for every 8 ventilated patients, you prevent only 1 death, and for every 25 patients that are requiring oxygen, you only prevent 1 death. And I'm not very impressed by this. So they use dexamethasone 6 milligrams for 7 days. So it reduced the 28-day by 17%. So I'm thinking maybe my protocol might reduce it, or like not my protocol, like Prof's and that study from Spain's protocol may reduce it even more. And we are seeing better results. And remember, the recovery trial is preliminary result. Now, remember, they even started their dexamethasone a little bit later than when we started the dexamethasone. We're already starting it in the mnemonic phase. They're starting it a little bit later than just giving oxygen alone. So that's also the difference between the recovery trial. Now I will show you a study. So this is the study to look out for. They are using the 10 milligrams PD and the 5 milligrams PD. They say their results might be out in October 2020. Oh no, October 2020. So this is the study that needs to be looked out for. So we will look out for that. So coagulopathy, we know all these messages coming from the lay public and from everyone that the virus is associated with a coagulopathy. We know this in sepsis. So what is sepsis? Sepsis is an imbalance of pro-inflammatory and anti-inflammatory. Sepsis is an imbalance in procoagulants and anticoagulants. The only thing with SARS-CoV-2 is this anticoagulants, the procoagulants is much more pronounced. The IL-6s are very high. The D dimers are so high. In fact, the D dimers, we know a D dimer, a positive D dimer, we can't say anything, but it's a marker of infection and inflammation as well. So the D dimers are high, and that actually can show you the prognosis of a patient. So that is why anticoagulation is so important in these patients. So that's why thromboprophylaxis is so important, right? In severe cases, it's definitely associated with the coagulopathy. You need to consult the specialist, and the time at which the coagulopathy happens is around the time where they become hypoxic, right? The main thing is mobilize. Even in the bed, if they able to do calf exercises, so lift their dorsum of their foot towards them, that will be better. But we know these patients are weak, and especially in those 3-4 days of when they're getting this inflammatory response, it's very difficult for them to mobilize. So we need to try and get away. So initially I was very worried about the patients. I was like, okay, now I'm going to start the prednisone. I know what to do there, but what am I going to do about anticoagulation? What if these patients get a pulmonary embolus? And I was very stressed out. So I did consult the profs, and I'll discuss that a little bit later, right? So anti-platelet agent. So there's a whole hype about aspirin and giving aspirin. And if aspirin had no side effects, I would have said, yeah, start it on anyone. But aspirin does have side effects. The studies are still ongoing. There's another study I'll show you that we must look out for. But the ones that are available show controversial data, and it does not warrant to start clinically, especially on healthy patients, right? We can continue a low dose of aspirin, like 75 to 81 milligrams. The 75 milligrams are not coated, so they can still get ulcers and bleeding gastritis and all of that. The 81 milligrams, the Ecotrin that's commonly used, that one is coated, and it's said to prevent that. Patients with comorbidities who are obese, who have a BMI more than 30, who have hypertensive, who have ischemic heart disease, diabetics, we can give them a low dose of aspirin because the risk of hemorrhage in them, according to the Canadian study, is low. But there is a risk of hemorrhage, right? Then they looked at other antiplatelets like clopidogrel. So they looked at all of them, but the risk of hemorrhage is too high in terms of these antiplatelet agents. So I added this in, and you guys can go look at this. It's in the stroke guidelines, where they looked at a whole lot of studies, and you can see in these guidelines that there's a very high risk of hemorrhage with aspirin. The lower the dose, and they say less than 100 milligrams, there's less risk of hemorrhage, but there can still be a risk of hemorrhage, and they don't know because they haven't assessed the duration also of the aspirin use, because aspirin we know affects the platelets, right? However, why people are looking at aspirin, because it has anti-inflammatory effects as well. So this is the study to look out for. They should be coming out, I think they also said August or October. So we must look out for this study and see what they say. They're using 100 milligrams of aspirin. If the study, so far the study hasn't been stopped yet, so it means that maybe they're not getting the hemorrhage complications. But I think for now, the healthy young patients are getting better without aspirin. So I don't think we must add aspirin for them at all. The thing that we should add for people is anticoagulation. So as I said, I was very stressed out. I said, I'm doing right in the one end, and then in the other end, how are we going to get over this increased coagulation? So we use factor 10 inhibitors, right? So it's Clexane or heparin versus Rivaroxaban. Internationally, they used heparin infusion, and of course, we cannot use that at home. So let me tell you guys the difference between Clexane and Rivaroxaban. I'm not going to tell you about mechanism of action and all that there. I'm just going to tell you about what you guys need to know. Clexane needs to be monitored. It is very variable. One day the anti-factor 10A level is 0.2, and then the next day the anti-factor 10A level is 1. So it needs to be monitored. It affects the platelets. You get hit. Heparin-induced thrombotic thrombocytopenia. So you get, so it affects the platelets. And then it's affected by renal function. So now the patient has completely normal renal function. You give them 40 milligrams of Clexane subcut, and then they become dehydrated, and you don't know because we're not taking bloods often. And they get an AKI, and now the Clexane is, so it's not good to use at home. So I consulted with Prof. Mer, Prof. Richards, and Dr. Carla, 3 of them. I said, I'm phoning all 3 of them, and I'm asking all 3 of them, what do I use? Can I use Xarelto? Because I was thinking about Xarelto or Rivaroxaban. And they all said, definitely, you can use Rivaroxaban, and they gave me criteria. And I still think that the GPs must be in consultation with the specialist for Rivaroxaban. So I've started using Rivaroxaban, and the GPs phone me, but you must see how good they are now. It's like, it's amazing. I just love our network, and I just love our unity. And it's so nice because we're all working so well together, and alhamdulillah, it's working. And inshallah, we can save more patients. Okay, then we go to prophylactic first therapeutic. Let me go to the next slide, and how long, but I just want to go to the next slide. Okay, so this is done from a Saudi Arabia trial, and they're using D-dimers. So they're using high risk of thromboembolism and low risk of thromboembolism. But what we're using is the D-dimers in hospital. So if the D-dimers are more than 1, then I'm giving them therapeutic stuff. And this is coming from Prof. Mer and Prof. Richards, their guidelines. If the D-dimers are less than 1, then I'm actually using prophylactic doses. And then at home, I use Rivaroxaban therapeutic or prophylactic, but I look at the BMI, I look how hypoxic they are, I look at their risk factors, I look at the mobility. The thing that we don't know is how long. So everyone doesn't know how long because this disease is very new. There's a lot that we don't know about this disease, but we can use it till they off the oxygen, right? So they become, they're not hypoxic anymore, and also they mobile. So once people are mobile and they haven't had any other problems before, then we can stop the anticoagulation. Okay, so we went LV fast. Now we come to leg up. So lung exercises. So lung exercises are very important. The one thing that's important is prone position. I'm not going to go too much into this because we have a very good talk that's coming next. So if the patients can't prone, especially the pregnant patients, the obese patients, they hate proning, but even with the obese patients, tell them to put a pillow on their chest and on their pelvis and let the abdomen be free, and that's how they must prone, okay? And then just tell them, if they can't, then they must sit in 90 degrees, not 45, 90 degrees, upright, or stand upright for 30 minutes every 2 hours. So they can choose what they want to do, but they must do one or the other because it helps them. Then lung exercises. So Gideoni explained 2 types of lungs in this disease. One is the phenotype H and L, and it's to do with elastance or compliance. I'm not going to go too much into detail about it, but the one apparently did not got worse with P. As I look after more patients, I'm starting to believe that a bit less because I feel that patients are actually needing both. Patients, they need APRV, but they need the proning for at least 24 hours, and then I put them supine. These are my intubated patients, and then they're much better in terms of ventilation. So in the mild patients, you tell them blow a balloon or blow water through a straw or in an isolated room and test. If your sets go down, then don't carry on. If your sets go up, then do this at least 10 to 12 times per day. Okay, so this, you don't have to know details about this, but I just want to show you, right? In the supine position, the mouse is not down. In the supine position, right? If you see, this is non-aerated, right? And this is, in the supine position, perfused. So non-aerated, perfused. Not so decreased perfusion, well aerated. Can you see that VQ mismatch? So V, ventilation, perfusion mismatch. Whereas in the prone position, right, well aerated, well perfused. Non-aerated, non-perfused. Can you see how much better your matching of your ventilation perfusion has become? And that is why perfusion is so important. And that is why I wanted to show you guys the slide, because a lot of people ask me this question. Okay, antibiotics. Oh my word. This is such a difficult topic. It's a viral pneumonia. It's not a bacterial pneumonia. It's a viral pneumonia. It's not a bacterial pneumonia. I am seeing so much of bacterial resistance. When patients come in, their urine infection, they resistant to Augmentin. No, they're sensitive to a carbapenem. What is going to happen to us? What antibiotic are we going to use when we have to start using linezolids and tigecyclines in the ICU immediately when the community comes in ICU? After that, where are we going to go? We're just going to look at our patients dying. And that is why I stress so much about antibiotics. I stress so much that, you know what, do not give antibiotics unnecessarily. I stress because antibiotics is not, it's not a drug which has no implications or consequences. So things that have no impact, like if people want to use some, like something where I see Okay, sorry, I got lost. Josefa, can you hear me?
G doctor, you're back now.
And you can see my slide, right?
G,
I'm almost
antibiotic.
okay, and Dr. Isop, I'm almost done, okay? All right. So, you see, I can talk so long about this, but I'm so passionate and I really want to help people. That's why I'm so sorry. So, azithromycin is used for immunomodulation in bacterial pneumonias, okay? But that's why they tried to look at it in COVID. And there's also studies with azithro and hydroxychloroquine and azithro alone. There's no proven benefit in viral infection, particularly in COVID, okay? Because they looked at it in COVID. In fact, it prolongs QT. You can get toussaint, and arrhythmias, okay? And remember, if you're going to add an antibiotic, that also prolongs QT. So that you can also cause toussaint. It's not bacterial, so don't start antibiotics unless the PCT is high, right? So that's why it's so important. Glucose control is very important. You must monitor the HTTs, especially in the diabetics. There's studies that are coming that it affects the beta cells. I don't think it will cause diabetes itself, right? So that also look at the studies with caution. It does the DKA patients, that we're finding it difficult for them to get out of DKA. So that it does affect, but causing diabetes, that's still, we must still look at that with caution, right? At home, we were able to manage with oral hypoglycemics and insulin. And remember that steroids impact the glucose. With DKA patients, they're very ill. They should be managed in a hospital setting, but I'm afraid in time to come, if this is not the peak, and if people are saying this is not the peak, we're going to have to manage DKA patients at home. So Dr. Vidal, who's a part of the IMA, and me, once I get a little bit of time, I want to try and set guidelines with him for the DKA management patients at home, only if we are stuck. So the other things, symptom monitoring, 4 to 8 hourly, mental status, SATs, respiratory rate, heart rate, temperature, and you can see how the family must be involved in this, because how is the patient going to do this all by themselves? And they must just send you guys WhatsApp, because I know everyone is very busy during this time, and you guys will pick up when you need to pick it up. So you just need to tell the patient that. Symptom control, people are asking me about steaming and nebulization. So steaming works very well. People are getting very tight-chested on like 3 days to 4 days after symptoms. So I noticed the nebulization works. It is an air cell generating procedure, so they must be in an isolated room, in a well-ventilated room. If it's just a tight chest, no wheezing, give them saline nebs. If it's a very with wheezing, then rather give them Duolin or Combivent. Remember the palpitations, the tremors, so you must half the dose if they are getting that. And BP control in patients who are hypertensive. And then the bloods. I do FPC for your home bloods. I do FPC, UNECRP, PCT, INR, PTT, cardiac enzymes, D-dimers, and IL-6. IL-6 plus minus if the patient can afford it or if the medical aid is paying for it. I don't do ferritin, I don't do LDH, because CRP is the D-dimers is going to give me my answer that this is an inflammatory response, and it doesn't change my management. And the cardiac enzymes, the TROP-Ts do go a little bit high, and we must just monitor that. And that's the end of my presentation. Maaf that I took so long. And I hope that helps. Jazakallah.
Jazakallah khair, Dr. Fatima. It was really interesting and we could listen to you for hours. We were really enthralled by the thing. I'm sure the most obvious thing that comes through is your passion and your care for the community. So we'd like to thank you and we'd ask you to hang around for the panel discussion a bit later. Okay. For those of you who are just joining us, welcome to the second Webima hosted by the Islamic Medical Association of South Africa. Once again, some housekeeping rules. We've got quite a few unknown guests or sort of very cryptic usernames, some very creative ones also. I need to urge you to please give Sister either register with your full name or give Sister Kashifa a WhatsApp or an email with your full details, because that's the only way we'll be able to issue the certificates. As far as the CPD certificates are concerned, those of you that don't know, we are registered for 2 clinical CPD points and 1 ethical. Just remember, for those that have paid, the CPD certificates will be emailed to you. Make sure your details are all right on there. As far as other housekeeping rules are concerned, remember there will be a recording later. Make sure to mute your video. If you want breaks, you can go for a tea break anytime you want. We won't police you and we won't ask you questions. Our next speaker, once again, alhamdulillah, today we are blessed with some very passionate speakers and all very involved in their communities. Our next speaker is Naima Acute, who's a physiotherapist in private practice. I'm just going to get up her CV here because, you know, they not only are they very passionate, but they're very humble. So they're cutting down their CVs just so that I don't embarrass them too much. But I think it's important that we acknowledge their experience, their expertise, their passion for the community, and their concern for our community. So our next speaker is Naima Acute, who's a physiotherapist in private practice. She's also the Professional Development Information Officer for the South African Society of Physiotherapy. She's quite passionate about sports physiotherapy and has been also involved now with the, I don't know if many of you have seen the PEP project that the physiotherapists are going on. In fact, there's a video which we couldn't upload about it, where they have this project. Dr. Fatima just highlighted the importance of lung physio, of mobilization, of recruitment exercises, and those type of things. And this PEP project is now a national project where they're trying to get as much of these devices out there where patients can use for lung physiotherapy. So I'm going to hand you over to Naima, who's going to talk to us about the physiotherapist's perspective on lung health, both in hospital settings and at home. Naima.
Naima, I think you might be on mute.
alaikum. Can you hear me?
Loud and clear name.
Okay, Bismillahirrahmanirrahim. Assalamu alaikum to everyone and shukran. PowerPoint and presentation, and from a physio perspective, it also gives us a lot of insight into understanding the condition and in terms of medical management, so we know how we can collaborate our management as well. Can everyone see the PowerPoint?
Yes.
Okay. So today's discussion is looking at maintaining good lung health pre, intra, and post COVID-19. This is applicable to the general public as well as practitioners treating patients, etc. So information from today is mainly from a lot of studies we've gotten, obviously not much in South Africa, but a lot from Italy, the UK, etc. And a lot of input from clinicians on the ground working in the different ICUs, especially the ones. So, sorry, I just want to get this working. So again, I'd just like to make a special mention to Yasmin, Umar, physiotherapists for their input as well. We know Lenmed has been having quite a high number or caseload of COVID patients. So thank you a lot to her for her input as well. So looking at the role of physiotherapy, we understand our health system is currently very, very strained, and it was already strained prior to the pandemic. And the lack of capacity requires interventions which are going to be sustainable going forward. We know we don't have capacity for increased hospital beds. We know we need to get patients discharged as soon as possible, but as safely as possible as well. And so physiotherapy can be a tool to assist in reducing the length of hospital stay and significantly reducing costs associated with prolonged admissions. Our role extends far beyond just clinical practice.
The presentation has stopped. We don't see any of the slides at the moment.
Okay, let me just check. I'm just uploading it and seeing again. Is it showing now?
Yeah, it's showing the PowerPoint that you're in PowerPoint here. Perfect.
Has the slideshow continued?
Yes, now it's continuing.
Okay, shukran. Sorry about that. Like I was saying, our role extends far beyond clinical practice, and we know from undergraduate studies that public health, the role of physiotherapy in public health is really important. And I think we almost limit public health to our rural blocks and experience, but it's definitely not limited to that. Our role of prevention, promotion, and advocacy within our communities, especially we have the advantage of being Muslim health practitioners. We have the Islamic ethos to apply to the scientific background and principles to really communicate with our patients, to educate the communities around us, and every opportunity we get to go for health promotion and education, encourage the proper use of masks, infection control. In terms of advocacy, we also have a major role to play in terms of advocating for vulnerable groups, particularly those with disabilities. At the moment, they aren't being prioritized, and it's important that we ensure access to healthcare for those patients as well. So that's just a quick outline of the presentation. We look at the physiotherapy timeline. I've broken it down into various stages, but it's important to note we understand patients may fluctuate from stage, maybe ICU admission to the ward and back to ICU, or they may just fluctuate variably across the continuum of care. And so it's important that we look from pre-COVID stages that everybody at home now, we want to facilitate a good pre-admission level of health. And so maintenance of good lung volumes, maintenance and improvement of cardiopulmonary fitness and endurance, because we've seen and we've heard from so many of the clinicians that the pre-admission condition of the patient really affects their recovery. So our doctor mentioned increased BMI, etc. These all play a major role in terms of rehabilitation post-COVID. Intra-COVID, in terms of ICU, we need to look at the acute problems that we're focusing on, primarily chest complications, prevention and treatment. And then looking at the ward, we want to start to slightly increase endurance, improve activity, mobilization. And upon discharge, the most important thing is patient education, proper home programs to discharge patients with. And post-COVID-19 follow-ups are so important. The survivorship phase, I think, is often overlooked because of the crisis we're in. Everybody's in a hurry to try and treat the sick patients. But post-discharge, we want to prevent regression, we want to prevent readmission. And so education of patients, following up patients, like Dr. Lambert suggested, home visits where possible, virtual consults, cardiopulmonary rehabilitation. There's a lot of literature that supports it and the important role that it plays in ensuring these patients return to maximal function. Just in terms of precautions for physiotherapy, we know our general physiotherapy precautions and contraindications associated with ICU treatments within the ward. As Dr. mentioned, proper PPE, proper donning and doffing. The physios spend a lot of time with patients. Some physios have said they're spending an hour with patients on basic treatments because of the fatigue that these patients experience. So ensuring proper PPE, proper donning and doffing, we have very close contact with the patient, and so it's really important. Another important thing with the dyspnea is a high level of fatigue. And so we don't want to exacerbate symptoms, but we also want to make sure we push patients as much as they can be pushed. So monitor fatigue very carefully, and these patients desaturate very quickly. So to carefully monitor for signs of desaturation and ensuring our exercises and rehabilitation are graded. So ensure that we slowly progress the programs. The other general precautions, and ensure a thorough assessment, because it's very easy to miss underlying conditions, to maybe not pick up pre-admission conditions as well. So if we look at pre-COVID, this is for patients. Sorry, I just see a message that I should just minimize here. There we go. If we look at the pre-COVID stage, this is for hopefully patients that won't eventually get COVID, or those who do, they come in with some experience or understanding of the breathing exercises, so that when they do have to do it in hospital, it's a lot easier. One important thing that's been mentioned is a lot of patients with underlying conditions such as asthma, etc., have not been using their proper prescriptions to date. And so it's really important that pre-COVID, all the patients are using their inhalers properly, using whatever has been already prescribed to follow that properly according to prescription. And then important that we maintain and improve lung volumes. There's a lot of exercises out there, a lot of videos. And I have a video from the group created the PEP bottles. If there's time, we'll play it. Just had some technical difficulties, but it's really integral that everybody is doing proper active cycle of breathing techniques. There's plenty of videos available online, and if anyone needs the resources, we're happy to share. Again, ensuring respiratory muscle strength, active movements and exercises, and a lot of patient education. We need people to be out there. We need people to be active. If it's something as minimal as a walk a day, but consistently doing something active to ensure cardiopulmonary endurance is maintained. Again, suggestions. The active cycle of breathing technique has been really effective in hospital. So prior to hospital, it works on breathing control, thoracic expansion, the forced expiratory technique. So there's a whole incorporation of increased lung volumes as well as respiratory muscle training. Again, ensuring active exercises. There's a lot of videos encouraging balloon blowing, pursed lip breathing, again, home PEP bottle devices. Now, when we get to ICU, intra-COVID, I think physio plays a very crucial role here, and I think the doctors can agree as well. Despite the fact that these patients experience major fatigue and experience dyspnea, it's really important that physiotherapy is initiated as soon as possible, because it's very quick. The time frame that patients may have the potential to deteriorate, particularly once they are ventilated. And so on these ventilated patients, we're talking about more severe cases, airway management, suction of these patients, our general physiotherapy management of the airway. Then if we look down to manual chest physiotherapy, again, ensuring we're not aggravating pain, particularly in the rib cage. But if there's secretion retention, using whatever techniques we have for secretion clearance. I want to stay clear of prescribing techniques per se, but looking more at aims of treatment so that we're not limiting the practitioners. But we've got the vibromass if patients can't handle the manual chest physio. We've got alveolar recruitment using manual hyperinflation. We've got to try and make sure that we're not having any collapses, any lobular collapses. And a very important point is positioning. I think it was mentioned earlier that proning, both active and passive, is really essential for these patients. A lot of the clinicians have reported significant improvement in saturation just from proning these patients. And so we talk about active and passive. I think in our experience of proning, it was more applicable to ARDS patients. But again, that picture that Dr. Lambert shared is very integral because it shows how much more we improve the perfusion and the ventilation perfusion ratio. The VQ mismatch in these patients is significant, and we really need to address it with proper positioning. And so I'll share later another suggested proning protocol. This was from one of the practitioners who suggested 1 hour every 6 hours. And passively is for patients that are not, that are maybe ventilated or sedated. Those patients can be left in prone for a bit longer. And active patients, the conscious patients, it is crucial that they are proning independently. Then again, the active cycle of breathing technique and circulatory exercises. It was mentioned before, the high risk of coagulation, the high risk of DVTs. It's really important that these patients are mobilized as early as possible and that adequate circulatory exercises happen. If the patient is too weak to mobilize out of bed, in-bed mobilization, rolling in bed, the ankle pumps, there are plenty of circulatory exercises as well as endurance exercises that patients can do in bed if they're not strong enough, particularly your older patients that are not able perhaps to mobilize too soon. Again, the general prevention of complications of bed rest. A lot of these patients are ventilated for prolonged periods of time, and the risks associated can be quite severe. We don't want to have contractures. We don't want to have any infections. We don't want to have any DVTs. So our general principles of management is really applicable and important here. Again, early mobilization cannot be stressed enough. We really need to push mobilization. If the patient cannot mobilize out of bed, at least mobilize to the chair. Bed mobility, mobilize in the room. The patients may have fatigue in between, so it's important we give them regular breaks, but we don't stop mobilizing. Again, active bed and room exercises. Very important that we grade the programs, that the patients don't get fatigued and that we don't exacerbate the symptoms. Again, if we look, we know that mental health plays a major role, and with physiotherapy, if patients are not, we don't get buy-in from patients and they're not an active part of their recovery and their rehab, it's very difficult to see good progress. And so we refer where necessary. There's a lot of counselors, psychologists working in the field. So I think it's an important thing to monitor for and to refer the minute we pick up any signs. And then another very important thing, because of the prolonged ventilation, the prolonged immobility, is to work on thoracic mobility. This can be through trunk rotations. Just the basic breathing exercises will also help assist with thoracic mobilization. And then very important that we try and work on those trunk rotations, even through the exercises, perhaps incorporate it into a functional activity. Again, now once these patients are discharged from ICU and they go to the ward, again, very important that we continue with the breathing exercises and ACBT. The active cycle of breathing technique cannot be stressed enough. I've heard from multiple physios in the field that this is one of the integral things that are showing major results in patients. And it's because it's such a holistic breathing exercise. It begins with diaphragmatic breathing control, and then we get the thoracic expansion, then we get it with the inspiratory sniff, so that we just really pop those alveoli open, and then finally the forced expiratory technique, so any secretions to be centralized to the trachea, and patients can then cough the secretions up. Once the patients are in the ward, depending on where their level is, very important we start progressing so that there's no regression and they don't plateau. So breathing exercises against resistance, balloon blowing, and here your incentive spirometry can be quite useful. There's a lot of devices out there that can be used to assist with breathing. Incentive spirometry is nice because we get good inspiration and forced expiration against resistance as well. Again, now we want more active secretion clearance. They're in the ward, they may be a bit more functional, moving, mobilizing. This is where we want them to actively clear their secretions. So this is where flatter devices and your PEP bottles come in handy. And this is something they can take home with them and continue at home. Again, graded endurance and resistance exercises. Remember, these patients have been in bed for a very long time, so we need to work on muscle strengthening, again graded, but endurance as well, so that they can do activities functionally because of the high level of fatigue. Active movement and exercise, and I keep on reiterating patient education. This is vital for patients to understand why we're pushing with rehabilitation, why we want to encourage the proper use of the devices. If patients understand, they're more likely to cooperate, and these patients are really willing to do whatever it takes to try and improve their current level. Now upon discharge, once patients are ready for discharge, it's very important. This is actually the role where we need to make sure we're not just discharging and then the patients are not followed up. Continue with ACBT and breathing exercises, and a thorough, clear, if you can have it written up or typed up, home exercise program upon discharge. Give them a weaning a protocol on proning. It's really important that they understand the proning protocols, how to follow it, because the active proning is really significant, and patients will tell you once they prone for a certain time period, they can check SATs. You know, a lot of them have the home SATs monitors. They see significant improvements in hospital as well. Again, progress the ward exercise. So you've been doing a ward exercise program. Now progress it so that they can continue it at home. And again, upon discharge is the most important time. These patients have been in isolation for a very long time. They're desperate to get home. They're desperate to try and get out, have some interaction. It's very important we educate, reinforce infection control, reinforce the need for isolation upon discharge, even for their family's sake, social distancing, and the importance of continuing the exercises. And again, upon discharge, ensure appropriate referral for counseling. A lot of these patients are living in a lot of fear. I think it's a time of fear for everybody. They're either fearful of getting the virus, or they're fearful once the virus comes, what will the repercussions be? And these mental health issues have major implications towards the patient's recovery. This is a self-proning protocol from the Intensive Care Society that was published recently. I thought it's quite useful. I know a lot of the hospitals have their own personal ones, so it depends what your hospital is using, etc. But this one's quite useful to give to patients upon discharge, and I've got the document if anyone would like it. This is just a straightforward explanation to the patients, and this is quite nice. It rotates. It's a cycle which rotates from prone to side lying and then going into head up tilt to 30 to 60 degrees. So there's a full rotation, which encourages active movement of the patient, proper positioning, and it's got good illustrations as well for home use. And I think it's really important that this doesn't get missed upon discharge. And then another thing, once patients are discharged, the survivorship phase is really important that we follow these patients up. Dr. Lambert mentioned home visits, and the physicians offering home visits, not necessarily about, not a lot of the physios are not necessarily doing the home visits, but maybe virtual consults. It's either due to not enough PPE, physio's own health risks, all of those things. But whatever the case is, whether it's a home visit or it's a virtual consult, these patients need to be followed up. There was a case study just recently from one of the hospitals. The patient was admitted to COVID ICU and then to the ward. The total admission time was 28 days. They had physio along with the proper management from the doctor, the nurses, etc. And upon discharge, this patient had tested negative. So at this point, it's very easy to feel comfortable that treatment has been effective, the patient is a full recovery, and the patient was discharged. A few days later, the physio practice was informed that the patient had passed away. And I think it's a wake-up call for all of us to realize that upon discharge of these patients, we cannot leave it at that point. The follow-up is essential. And I spoke to a few of the practices. A lot are saying they are overwhelmed because they're working in the ICUs and in the wards. They don't have capacity to do the home visits. And I understand that, but there are a lot of physios that are maybe not in hospital, working in hospital with outpatient practices. Our practice has now begun offering virtual consults, so follow-up of all discharge patients post-COVID. So really upon discharge, I think it's crucial they get referred for physio at home, so either at home or through a virtual consult. And this just allows the patients to maybe touch base with the physio, give a follow-up of their breathing exercises. You can progress the exercise program, you can monitor the cardiopulmonary rehab, and a lot of them have their SATS monitors at home that can almost give some input. Although saying that, it's very important that we know those machines work. Sometimes we know they can be inaccurate, and then it can pose a risk because we don't want them to desaturate too far. So it's really important, again, that I reiterate, the practitioners and patients also need to realize that discharge is not the end of the road to recovery. We have to follow up properly, and we need to ensure that progression of exercises is going to ensure functionality and return to work, return to normal daily activities. Again, the cardiopulmonary rehab, there's plenty of literature supporting cardiopulmonary rehab, particularly in these patients, and saying that we are missing a lot of these patients once they are discharged. A lot of them come back for readmissions, and it's quite crucial that they're not getting lost in the system. By this point, they should be a bit more functional, their symptoms should be less severe. Then we need to really push with muscle strengthening exercises, push for more advanced exercise program, but this is why it's important that we monitor these patients. And again, once they are at home, the proning does not stop. They have to continue with the proning protocols. Depending on the protocol, that one I suggested is nicely spaced out throughout the day, 30 minutes and then a break, 30 minutes and then a break. Other practices prefer 1 hour straight every 6 hours. So it really depends on your patient and what you feel is best for the patient, but they need to understand that the conscious proning is essential to allowing with that VQ mismatch to try and address it. Again, just one thing, a lot of patients are hesitant to prone because of spinal issues, previous surgery, it's a bit of discomfort. So make sure we educate with proper pillow positioning to avoid any discomfort to the neuromusculoskeletal system. And if there may be some discomfort, then to show them other exercises to alleviate those symptoms. Again, patients to continue the use of the blow bottle, breathing exercises, and ACBT. The PEP bottle is really important because it creates that resistance to mobilize the secretions from the lung, centralize it to the trachea. And it's really important that patients understand why we are giving them the exercises that we give them. And they must remain active. They must continue with circulatory exercises. We had a physio herself who had tested positive, and she explained that had she not been a physio, she wouldn't have known to do circulatory exercises, to do deep breathing exercises. And I think patients need to know there's more that can be done beyond medication. There's more that can be done to assist with their recovery. Just to end off in conclusion, to all of our physios, it's really important that we understand the role that we play. It's not a passive role. We have an active role to play in this pandemic. And like I said, our role is not just about clinical care. Our role extends far beyond community education, the public health campaigns, making sure, even when you're out and doing runs or errands, when you see an opportunity for education, sometimes people's masks are inappropriately worn. All of those little things make a big difference for people to understand. We have a major role to play, and especially in ICU, in hospital, these patients are really struggling with just maintaining SATs, and we really have the potential to assist them, grant them comfort and ease. And, you know, it's important that we acknowledge that as Muslim healthcare professionals, we have Islam, and alhamdulillah, I think that's an even bigger blessing. And to incorporate that knowledge and integrate that knowledge with the secular knowledge we've obtained, scientific evidence, all the articles and studies that we are seeing, to understand that we are the means of shifa, and we don't cure the patients, but we are just a means. I think we must really take up that responsibility. And I'm making a call to all the physios that are not working actively in hospital. I know some may have health risks which limit them from physically seeing the patients. In those cases, use the technology we have, use the virtual consults. When these patients need cardiopulmonary rehabilitation, it's not necessary all the time to physically be there. Yes, it's better, but with the situation, we've got to adapt. We've got to use the resources we have currently, and I think patients will really be appreciative, and you know, the long-term repercussions of having physio, the long-term implications of physio can really reduce the risk of in-hospital stay, can really reduce the risk of readmission and regression of these patients. And I think the family is also, patient and family caregiver education is really integral, that the patients understand, and the family, more importantly, that the family understand how those exercises must be done in that. But again, like Dr. mentioned, the families sometimes need PPE. The families need to learn and realize or understand that isolation from the patient is important once they discharge from hospital. All these things make a very big difference. I'll just reiterate, we mustn't underestimate the post-discharge follow-ups in the cardiac rehab. And again, get involved wherever you can. There's a lot of campaigns. The Ppe bottle campaign has been really effective. They'll be now developing and distributing it, and it's integral. We don't have the resources and we need to adapt. We can't sit back and be complacent, but now's the time to be proactive and use the skills that we have. And remember, this is to all the healthcare practitioners. We don't have to fight this alone. Use the multidisciplinary team that's around you. Use the NGOs like the Islamic Medical Association that's around you. There's so many opportunities for collaboration. You don't have to take the burden on yourself. And I think it's really important that you monitor yourself for signs of strain, signs of fatigue, signs of, you know, those are expected, but signs of burnout, because we need our practitioners to be at the best health they can be to provide the best services. There's been a lot of physiotherapists that have tested positive from working in hospital, and obviously it's had major implications because now there's a reduced physio team force in the hospital, and we already know that the ratio of physiotherapists to people in this country is very, very significant. There already aren't enough physiotherapists out there, so whoever is working, we need you to take care of yourself, and remember, work with a team. You don't have to handle everything alone. Make sure you refer appropriately. Have proper engagements with the doctors. Discuss where necessary. I think MDT meetings are important. I understand patients are, practitioners are overwhelmed with the capacity at the moment and the patient loads. But even if it means just touching base now and again with the team, with the nurses, monitor how was the patient today, how was the patient overnight, monitor with the doctors. I think for the doctor and physio communication is essential to understand that nobody misses important information. A lot of practitioners have also explained that in the ICUs, the physios are the eyes and the ears for a lot of the doctors, because we spend so much time with these patients. We can pick up smaller things, we can really identify, and there's been really heartwarming stories coming from physiotherapists in the field talking about how patients are so grateful for the little things. You teach them ACBT and they are so grateful because they're able to breathe a lot more comfortably. They learn to prone properly and they see their SATs, you know, use the SATs monitors in hospital, use the ventilators in hospital as visual feedback for these patients. They can physically see an improvement with the physiotherapy, and I think it's an encouragement for them to see they are progressing, they are getting better, and recovery is on its way. Small things physios have said, you know, patients have asked, you know, and this is the beauty of being a Muslim health practitioner, is patients have asked physios to help them. They've lost muscle strength in their arms, but they want to hold their arms up for a dua and ask the physios for assistance like that. And we must think of these things, you know, as Muslims. Patients want to get back to reading Salah properly again, maybe standing and on the floor. These little things that we have the advantage of having the understanding, and physiotherapy can really be integral in fulfilling those roles. And so we appreciate and acknowledge all the feedback, all the input, and all the efforts from everybody out there. And we continue to make dua for everyone's safety and for the success in managing this pandemic, managing the patients. And we just put in all the efforts we can and trust in Allah that whatever is to come, we'll be able to cope with it. You have understood a little bit more about the role of physiotherapy and that you go and apply this. There's plenty of resources available. For South Africa, we don't have too much literature yet. There's still pending studies, but there are plenty of studies from the UK, Italy, etc., talking about physiotherapy, cardiopulmonary rehab. And so I've left a long list of references here, very useful studies that we use for this. We're using at the SASP for our protocols for Department of Health. These studies are really useful to understand how exactly physiotherapy can impact COVID-19. And then there's other documents that are not here. If anybody requires, I'm happy to share them. You can just contact IMA. The proning protocol, particularly for patients upon discharge, I think is quite essential. And you can even adapt it to in-hospital use. And then a proper home exercise program. Jazakallah khair. I hope that's helped. I'm not sure how we are on time in terms of sending the videos. I'm just trying to see, Huzaifa, have we got enough time?
I think, Naima, we have some time for the video if you want to play it.
Ma, sorry, I didn't hear that.
You can play the video, Naima. It should be fine.
Okay, I just hope it's going to work. I'm just waiting for it to load. So just while we're waiting for this video, the PEP bottle campaign has really been responded to in such a wonderful way from the communities and everybody willing to donate and contribute as much as they can. I often hear people asking, how can they contribute? I think this is an essential way to get involved. I just want to see, is this playing now? Okay, I think I'm going to try just for one more minute. If it So if we look at this, I think it still seems to be loading. Just to understand the project a little bit more, we've got our physios, Zaytun and Safia, that made the video itself.
Yeah, perhaps Naima, you can go ahead and just give us an explanation of the project, and then we can share this with Kashfa with the on the WhatsApp groups.
Yeah, I think we'll rather do that. Let me just go out of this. So if we look here, the PEP bottle campaign is basically trying to provide resources to patients at home to try and reduce the strain on the hospitals by admitting patients who can maybe be managed at home. So you can always check with Zaytun and Sophia a little bit more afterwards if you need the contact details about the campaign itself. But it's about developing the PEP devices that patients can use at home to try and mobilize secretions, assist with respiratory muscle strength training, and incorporate it into the home exercise program, incorporate it into the active cycle of breathing technique. What we will do is maybe share the video after the presentation, and I think that's all from my side. I hope, inshallah, it's just clarified in terms of the role of physiotherapy, where we come in the case of these patients, and inshallah, Jazakallah for the opportunity, and I'll hand over back to Dr. Zahir.
Jazakallah khair, Naima. That was very informative and gave us a bit of insight into what you guys do as physios during the COVID in all sectors of the clinical course of the patients. I think what's really come through is the passion that both our first two speakers have had regarding helping our community. I think a lot of the information is out there, but the way we access the information and the way we use the information is not as obvious, and it's quite difficult at times. So I think one important thing to remember is how Naima put it, that we should just try and be the means of helping our patients. There's nothing greater than it, and no greater reward than that. I mean, Allah says in the Quran, "A'udhu billahi minash shaitanir rajim, wa idha maridtu fahuwa yashfin." So whoever's ill, Allah Ta'ala is going to grant them shifa. It's amazing that we can be of benefit to them. So we're going to take some questions for Naima and Fatima. Dr. Fatima needs to go and do what she does best in ICU. So I'm just going to run through some of the questions on the chat. If any more of you have questions, we'll take questions till about 12:05. Our first question for Dr. Fatima, can you hear me?
Chia, I can hear you.
Okay, so Rana Bayer says, as a pharmacist, it's with great concern that we see the increased dispensing of steroids to patients with mild or severe cough, and given obviously the immunosuppressant that you've discussed.
Yeah.
So she says, what advice can pharmacists give these patients about taking the steroids? And she wants to know if there's a place for inhaled corticosteroids,
okay,
as part of the systemic home-based care of these patients. And then what about, because we're worried about aerosolization, what about things like using an MDI as opposed to a nebulizer?
Okay, so Rihanna, Jazakallah for the question. So the first thing you can actually tell the patients, be straight and honest, because patients also, if they educated, I think they will be able to follow. I feel if everyone's educated, they'll be able to follow. So just tell them about the steroids that can give immunosuppression, and in mild patients, it might make it worse. The second thing is, I don't think there's a place for inhaled corticosteroids, because they just get a tight chest and they just get a bronchospasm, and that's when the wheezing comes in. So the normal saline nebs is helping with just the tight chest, and the Duolin or Combivent is helping. I'm scared to give inhaled corticosteroids because COVID is a lung disease.
That's his daughter.
My daughter, she wants Oreos. Does anyone have Oreos? Then the third question, instead of nebulization, right? So MDIs, there is a place if the patient knows how to, there is a place if the patient knows how to use the MDIs. But unfortunately, patients don't use it properly. Then I noticed that they say, but it's not working, and that's why I started using nebulization.
Okay, thanks for that one. And then somebody says, our next question then is about the timing of the corticosteroids. Once again, I mean, we spoke to this. I mean, we don't know what the timing is.
Yeah.
The next question is from Safia Dorat. She wants to know, can you clarify the WHO statement on the virus being airborne, and what are the implications for us?
Yeah, so I've read studies where in the one ward in China, the virus was actually found at 4 meters away. But as we know, we don't know how much of virus is needed for infectiousness. So we don't know how much virus needs to be shed for infectiousness, because I mean, it's such a new virus. So the microbiologists themselves don't know this. So even though they found the virus 4 meters away, it looked like the healthcare workers or patients, they weren't getting infected. So that's still in the air. I think you see they talk about small droplets and they talk about large droplets, and the virus is about 5 micrometers, and that's why they say it's more likely to dissolve in droplets rather than like TB where you can get it in the air. But they still say the main thing is ventilated rooms, and ventilation is the most important thing rather than looking at whether it's aerosolized, whether it's not aerosolized. So that's still a debate.
Okay. I think that's especially important for public areas like masjids, where even though it's cold and we can't use the air cons, we need to keep the windows open. I think that's quite important.
Yeah.
Okay, our next question for Dr. Lambert is from Reza Mullah. Jazakallah for the informative talk. What's the suggestion about initiating steroids for patients over 92% who've just got a cough and wheezing? We've essentially covered this, but just a quick reminder.
Yeah, just a reminder that if the patient is not hypoxic, then we do not give steroids. They're not in the pneumonic phase. Only when the patient becomes hypoxic, then we decide whether the patient needs steroids.
Fatima, I think we're gonna let you go now. I think you need to find some Oreos before you go to the ICU. We just like to say Jazakallah khair for taking your time out. Just one or two more questions.
Yes. I think Dr. Rashid Noor Mohammed is telling me about Clexane. Please don't give Clexane in the community. It's a
even Xarelto, Fatima?
The Xarelto you can give.
Okay.
But not the Clexane, right? And then the dexamethasone, I know it does come in 8 and 4. You can do that, but because like we're trying to get set data, you know, because I also want to try and get my protocol out. So if we have a set dose, then at least we can get some data from South Africa. Okay. And we can use a Venturi Mask if the nasal bronchitis.
And then just maybe quickly on colchicine, and
yes. I actually got 2 studies on that. It just came out recently, and the low dose of colchicine, they give 1 milligram stat and then 0.5 milligrams BD. And we started using it. It was a very small sample size, but what it showed that it actually helped with the cardiovascular side effects, like the myocarditis and all of that. So, I mean, that doesn't harm. So you can start it. It also has anti-inflammatory side effects. So you can start. Yeah.
Tell me just one other thing. In terms of the blood test, is it better to do a PCT or CRP adequate?
Both. Because PCT is going to show you your bacterial infection, right?
Okay, yes. So we know whether we can start antibiotics.
Inflammation. So CRP won't tell us is this from a bacterial or
Fatima, can you hear me? Fatima, can you hear us? I think we've lost Dr. Fatima. I think we can carry on with some questions for Naima regarding, I think just anecdotally, yesterday or day before yesterday, I was called to intubate a patient in the ICU. A Muslim lady who sat there with a respiratory rate of 16, but sets of 60. I asked people to prone the patient, but they didn't prone the patient. And when I got there, she still was sitting with sets of 60. Doctor, you need to intubate this patient. Patient is getting a bit alkalotic and patient's base excesses. And the big issue there, so all I did, and there's a bit of hesitancy, Naima can perhaps help us with this. There's hesitancy from the patients and from the staff to prone patients. It's a bit of a schlep in ICU to turn the patient with all the lines and wires and monitors going on. And at home, the patients don't like laying on their stomach for whatever reason. And all we did with this patient was physically turn her over onto her tummy for 2 hours. Immediately, as said, we went from 60 to 80%. So instead of intubating the patient, we managed to make the patient do so much better by proning. So perhaps from Naima's side, if you can share some of the protocols with the physios, some of the techniques, perhaps a visual you can send to Kashifa to share. But just for now, just explain to us the practicalities of that proning and how we can take away the schlep of it.
Jazakallah, Dr. Zahir, for that question. Look, I know it does seem like it's a bit more difficult, particularly on your ventilated patients when they've got lines from every angle, and the nurses generally are sometimes hesitant. They're worried to pull out the line and then it has to be reinserted. But if you look at the repercussions of not proning, it's really worth the effort. In the patients that are in the conscious patients, those proning protocols is more about them being consistent in committing to the protocol and committing to the program. Hospital itself, the nurses are quite familiar with just proning the patients. It's more about making sure there's a pillow under the pelvis to ensure comfort. You can even put a pillow under the feet once they're in the prone position. And then if they're very uncomfortable, which is expected, it's important on the patients that are maybe sedated and ventilated, you turn the head position from side to side occasionally so that we're not getting shortening of neck muscles in one direction. That's something to consider. But also, if they're struggling in prone for too long, it's fine. Then rotate them to sideline because you're still going to get expansion of the lateral lobes for the lung that's on top. Then you turn them to the other side. So inshallah, I'll send the proning protocol from the Intensive Care Society. It has very nice pictures to show exactly what positions we want these patients in. And I agree with you, using other techniques, alternatives, before we just rush to intubate these patients.
Fantastic. Dr. Fatima, and I think some of the LENS delegates, I think you guys have just got whacked with load shedding. So we might lose some of the delegates. We might also lose some of the administrators. If there's any issues, we'll try and proceed, inshallah. Naima, just one other thing when it comes to the proning of patients. For how long, just to advise patients, we all can use the protocol you've shared. If the patient says, no, he can't lie on his stomach, is there any benefit to just lying on his one side?
There is still benefit because it's one of the postural drainage positions that we use in normal chest physiotherapy. If you think we put the patient into left side lying, you can do either direct side lying with a pillow between the knees, or you can slightly rotate. So what's a beneficial way to do it then is, in the picture you'll see, you put a pillow on the side and slightly rotate the patient so they're on side lying, inside lying, and then you let them rest their right arm onto the pillow, which causes a slight rotation and a lot more space for expansion. Remember, the lung at the bottom is the one that's compressed. There you're not going to get proper expansion, but the lung at the top, you're going to get much better expansion, and that's where you can use your breathing techniques in those positions. So if they're struggling with prone, you can still do the side lying with a bit of rotation, but then make sure you're doing it to both sides so that both lungs get some positioning or ability for expansion to try and increase those lung volumes. The one reason why it can benefit is because most of the cases is that you get basal lung collapses. And so if you can get the basal lobes on either side, on the top we allow for more space for expansion. But obviously prone is ideal, but if you need to rotate, that's fine. On that note, it was actually, you know, one of the patients, one of the Muslim physios said that one of her Muslim patients said they're not allowed to prone because in their religion, Islamically, they can't lie on their stomach. You know, it's those things to think about. But the thing is, if this is an intervention that's going to help the patient, and I think that patient, when they saw their sats go up, then they suddenly complied with the program. So it's just to explain and educate patients properly that will make a big difference. In terms of the ventilated patients, again, like I said, just monitor that neck positioning. And you know, sometimes they put like notes at the patient's bedside or headside to say how many hourly turnings. So the one protocol is 1 hour in prone every 6 hours. The other protocol suggests 30 minutes every 2 hours, but in different positions. I hope that helps.
Fantastic, Jazakallah, Naima. Our time for questions is up. I see Dr. Fatima is still busy giving us some nice answers. She's still able to access our chat. So some of the questions we haven't answered are being answered on the chat live. I think we can move on to our last speaker now. He's a nephrologist, so hold your water, or maybe don't hold your water. Maybe go if you can. Our next speaker is Dr. Shoaib Wadi, who's a private practice, who's been a nephrologist for the last 15 years. He's quite well known to us in the Joburg area. He's a stalwart of the IMASA. He's the current vice president of IMASA. I think he won't want me to read too much of his CV because he might cut me off. But like I say, he's a nephrologist in private practice, practicing out of the East End and the Donald Gordon Medical Center. I'm going to hand over to Shuaib not to talk about sort of nephrology issues, but more the ethical challenges we're seeing during this COVID epidemic. You know, a lot of our discussions have been about home-based care, community challenges, community-based, therapy, which in the old days, most of this therapy would have been taking place at in a controlled environment in the hospital. The problem is we faced with the classical ethical challenges they've taught to us in medical school of how do we allocate resources? What is the most equitable? What is the most fair? And how do we do this? Is it rich comes first or first come, first serve, or what is it? And Shoaib is going to run through some of these ethical challenges, how we can overcome them, and perhaps brainstorm as a community how we can make these challenges easier to deal with. Shoaib.
Assalamu alaikum wa rahmatullahi wa barakatuh. Can you hear me, Zahir?
Coming across loud and clear, Shoaib.
Okay. So as you mentioned, I'm going to go through some of the ethical challenges which arise from COVID-19. These are my conflicts of interest. Most of you will know what the definition of medical ethics is. It's basically a system of moral principles that applies specific values to the practice of clinical medicine and research. And it's underpinned by these values. And you can refer back to these values to allow you to practice ethically. Okay, I'm going to give you another definition. Rationing. It's derived from the root rational or reasoning, and it's the act of limiting access to a scarce resource. And we know, obviously, this is something that has been done in South Africa and around the world, and is almost unavoidable in medical practice settings. It's matching the need to the resources available. Okay, just some definitions of some of the ethical frameworks which we use. So one of the ethical frameworks which is commonly used, this is not the principles and these are not the values that I'm talking about, which I'm sure you are familiar with, but some of the ethical frameworks that we use is something called consequentialism, which is a framework which says that the end justifies the means. And then there's two sort of major areas of consequentialism. The one is utilitarianism. That means you try and make sure that the maximum number of people benefit at the end, and then you sort of have a measure of what's the most good you can do. Okay, there's another type of consequentialism which says that you can't do the same amount of good for all parties. You need to actually prioritize certain individuals because society is not equal to start off with, and you can't practice equality because society begins unequally. So you need to have an equitable method of prioritizing those who will benefit the most. So you do the most moral good, and this may mean that you then prioritize vulnerable people or vulnerable societies who have really started off on the back foot already. So those are the but at the end, still the end will justify the means. So those are both, and then the means can be anything. You can do things which would otherwise be morally objectionable as long as the means are fulfilled. Deontological is what most of us are familiar with. It's the act of applying specific principles, and you know the specific principles that we apply. First, do no harm, beneficence, autonomy, justice. So those are the principles you will apply, and you will apply them to an individual and to a certain specific situation without necessarily taking into account the broad context of that situation. Although it doesn't mean you don't do that, but the means are just as important as the end in this particular instance. And then obviously there's ethical. There's an ethical school of thought which says that your ethical behavior comes out of your moral character. It depends on what type of person you are. So you build up your moral character, and then you don't use for specific principles, you use the wisdom which flows from that moral character, the courage which flows from that moral character, the sense of justice which flows from that moral character. And then somebody will be able to make a decision just based on that moral character. And that's probably the oldest form of ethics. Before ethics was codified, people went to a wise person in the situation and in the society and asked them, what's the right thing to do? And there's still some aspect of that which needs to be ingrained into modern ethical practice. Sometimes you need more wisdom and less principles. Okay, so this is just a breakdown of some of the deontological principles that we've been well taught. We base our principles on those well-known principles that you know of modern medical ethics. All right, sometimes it can benefit a small group of people, but you can harm other people if a big picture is not taken into account. For example, in the Life Isidomandi situation, the Gauteng government thought, we'll save a lot of money by taking these people out of this home and putting them into other NGO-based facilities, and then these people will not cost the government so much, and we can use that money for other resources. But in the end, those individuals were harmed significantly. Okay. Then underpinning all these systems of ethics is what informs your moral principles. So, I mean, there's something called natural law where people believe that morality is universal and unchangeable. That means everybody has the same moral, the whole of humanity has the same moral rules, and those moral rules are immutable. They go on forever. But there are others who believe that there's something called moral relativism, that morality is contextual. There's some things which were maybe deemed immoral in previous times, which are now morally acceptable. One example, for example, is homosexuality in the world context, which was widely believed to be immoral for centuries and millennia, and in the current context is thought to be morally acceptable. And then obviously you can base your moral principles on your religious beliefs. So, I mean, for most of us as Muslims, our moral principles will be underpinned by what was revealed in the Quran and what comes through as our religious beliefs through the example of the Prophet ﷺ. Okay, these are some of the advantages and disadvantages of looking at those different systems. You can treat everybody equally. You can favor the people using certain priorities. I'm not going to go through this in detail. These things are widely available, but just be aware that there's no perfect moral system that can be applied. But as Muslims, we would say that you would apply a moral system based on the character of the Prophet ﷺ and using some of those principles, the deontological principles, which we have been well taught. Okay. So this leaves you to answer some very difficult questions. This is just outside the context of COVID-19 in general. You know, how do you equate the life of one person to the equate of another person when you're trying to make these decisions? Is it when you're saying the end justifies the means? Does it mean that you will use the deaths of old people to save the lives of young people, which may happen? You may need to restrict resources to elderly people in old age homes to allow young kids to get rehydration solution to save their lives from severe diarrhea, or maybe redirect efforts which we're using to treat cardiovascular disease, to treat malaria in Africa, so that you can save more people's lives and younger people's lives. So those are the type of questions which arise and which need to be answered. We know that when it comes to cost, every life is almost determined in terms of what's it worth spending to save a life. And this is not just in the private sector, in the public sector as well. We know that rationing occurs widely. The number of ICU beds that are made available, whether treatments are recommended or treatments are approved, depends very much on the cost. So, for example, there's a disease called Fabry disease, for example, which costs like R1 million, 2 million rands a year to treat, and will prevent complications over 50 to 60 years and will prolong the lives of those people. But how many lives could you save with that 2 million lives a year that you would spend on one person? So those are the type of questions which governments and policymakers need to answer. We know already that rationing occurs even by patients because of this, because cost is an issue, because people need to pay for medical treatment. We know that if you, this is looking at the Kaiser Family Foundation, which is from the US and which tracks people who are on a specific medical insurance scheme in the US. And they did a survey and they found that 58% of people had been self-rationing. They had not given themselves some type of treatment. And I mean, anybody who's treated chronic patients in the private and public sector will know that patients sometimes don't pitch up for chronic visits because they didn't have taxi fare, or they don't fulfill their medical prescription because there's a co-payment. So people self-ration. They see their medical care just one aspect of their life, and they need to rationalize whether they're going to spend the money on the multivitamin or the omega-3, or whether they're going to spend it on getting lunch for their kids at school. So these are very real things, especially in a South African context. Okay, so there are many ways we can ration care. I'm just going to talk a bit about rationing because it's going to be a key part of how we treat COVID-19. And obviously, there's a free market way of rationing. You say survival of the fittest. If you can get it, if you can pay for it, you get it. But obviously, it may not be survival of the fittest. It may be survival of the greediest. It may be survival of the luckiest. And I'm not sure that this is the fairest system. And certainly from an Islamic perspective, this wouldn't be the fairest system in terms of access to care. We know that rationing can be systematic and it can be planned. And there are very, very few systems in South Africa which have done this until now. There's been a wide framework for provision of renal services and dialysis services in South Africa, and there's some rationing criteria. But we actively ration ICU beds in South Africa. We actively ration medications. There's an EDL process. These are all rationing processes. I don't know if you realize that having an essential drugs list is not just an evidence-based list, but it's a rationing process to say we will give medicines which the state can afford and which will be essential and which will save lives, rather than allowing physicians to control what they can prescribe. So these are all rationing processes. These are planned and systematic rationing processes. But the majority of our processes in South Africa are not rational, are not systematic, and are not planned. There are very few guidelines for most of the rationing that occurs in South Africa. And it's not just in the public sector. Medical aids obviously practice rationing all the time. They have criteria for admission to hospital. They have criteria for access to certain drugs. These are not free-for-alls. People need to fulfill certain criteria, jump through certain hoops. Some of that is to protect the patient, but some of that is certainly to protect the medical aid and to save funds. Okay. We know that as clinicians, we often ration at the bedside. We're looking at a patient and say, now this patient, is it worth doing a CAT scan for this patient today? Maybe it'll be better by tomorrow and we won't need to do the CAT scan. His confusion may settle down, and then we wait another day, and then if the confusion is better, we've saved a CAT scan. If the confusion is not better, we then scan the patient and found out that if we'd scanned him yesterday, we could have treated the bleed in the brain, but now it's too late. So we do practice rationing at the bedside. I mean, and most doctors have trained themselves to do this. And general practitioners are experts at this. They can't send every single patient for blood tests to the hospital. They can't send people who walk into their rooms because they're not sure whether it's a bacterial or viral infection for a PCT every time. They have to use some clinical judgment and make some decision as to whether they're going to ration care or they're going to give this patient the care that they may or may not need. Okay. The other thing about rationing is it can be implicit. That means it can be secret, it can be covert, it can be built in a way which the patient is not aware of. So the patient may, when he walks into the general practitioner's rooms, may not be aware that maybe the decision would be better. Yeah, the doctor's decision would be better if I had a chest X-ray and I had some bloods. And sometimes the doctor won't even offer the patient that option. Say, actually, you know, if you had a chest X-ray and had some blood tests, I could make a much better and more rational decision. And the patient was not given that option. And many times, it's because as general practitioners and doctors, we assume that the patient can't afford it, they can't get there, they don't have medical aids, it's going to be inconvenient. And so a lot of our decision making is paternalistic. We make a decision for the patient and we decide what's best for them. And it's largely based on trust, but it's not completely transparent. And then some hospitals, for example, they will have implicit and indirect rationing systems. So they'll say, for example, we will only do 10 CAT scans a day. no matter how many you request. If your patient is the 11th one, it must be done tomorrow. Or the ICU doctor will phone and say we have no beds. That's it. It's not our responsibility to make a plan for you. We filled all our beds. We don't have a bed. Or the GP will say, this is the antibiotic we give for cash paying patients, and that's the antibiotic we give for medical aid patients. Or Joe Jen was saying at some stage that for a foreign patient to be admitted, you have to pay 8,000 rands up front. So it's an obstacle you place in front of that patient. Okay, and obviously explicit rationing, which we do have in some areas, as I mentioned earlier, where you have written guidelines, it's transparent, there's some patient discussion, but that is actually in the minority of cases around the world. So while rationing and priority setting can be set by politicians or the government or health administrators and funders, clinicians are the ones who are practicing it at every level. We are the ones who have to do it. And sometimes we are the ones setting the priority or setting the rationing bar without any guidance from anybody else, and it can be widely different. Every physician can set it, or every clinician can set it at a different level, and that's when you get unfair decisions, where one physician will make a decision to give a certain treatment to a patient because he thinks they deserve it, whereas another hospital down the road will say this patient doesn't qualify for ICU because we don't have a bed. So you're just lucky to be in the wrong place at the wrong time. Okay, this is a statement made several years ago by an MP in the UK, and he said that rationing in Great Britain has been implicit, that means secret. It is a silent conspiracy between the dense, obscurating bureaucracy, intentionally avoiding written policy for macro allocation, and a publicly unaccountable medical profession, privately managing micro allocations so as to conceal life and death decisions from patients. Sounds very familiar to me. Okay, so I don't know why I'm stuck here. All right, okay, so explicit rationing, if you are going to be open about it, you need to then look at the processes, how you plan it, look at what political processes that need to be put into play is, and what technical guidelines are you going to use. Are you going to be prioritize certain groups? Are you going to prioritize efficiency? Are you going to aim for equity? What are the systems you're going to put in? And then you need to look at the mechanics of how to do it. But we need to remember that this is the country we live in. We live in a country where moral standards are not high, where the level of accountability is very low. So it's very easy for covert and implicit rationing systems to go under the radar and to be and to jeopardize the lives of patients. And then we then enter this whole COVID-19 pandemic with this milieu. That this is not just the flu. This is from the Emmanuel paper in the NEJM, which looked at the ethics surrounding NEJM and around COVID-19. And one of the initial points that they made is that the number of patients who are likely to be affected and the number of ICU admissions, the number of deaths is not going to be the same, even if we compare it to the flu, which it's patently not. If we have a severe epidemic of COVID-19, we're likely to need up to 3 times the number of beds in ICU as we would have had needed for the flu. So we're going to have stressed resources. So then this leaves us with some of the ethical questions which arise. This is by no means conclusive. COVID-19 is an ethical minefield and leads to a huge number of ethical questions because it's a large stress on a already constrained system, both in the public and private healthcare system. And as I alluded to, we have a system which is unfair, which is unequal, which is mired by corruption at every level, both in the private and the public sector. And then we impose this difficulty upon it. So these are just some of the questions. Obviously, there were major ethical questions around limiting of individual liberties, around the lockdowns, around the enforcing of mandatory behaviors like wearing masks and using hand sanitizer. There's major questions around digital tracking, which some countries are using, which, for example, your iPhone is able to do for you if you activate it and you activate the setting. Your iPhone can tell you if you're near somebody else who has registered themselves as a COVID-infected patient. And some countries are using that. Obviously, there's ethical questions which arise around disclosing status to third parties. So as a doctor, a medical professional, are you obliged to disclose the status to other people? Obviously, there's some risks there in terms of the confidentiality, the duty to confidentiality that you have. There's ethical questions which arise from patients being admitted to hospital and hospitals restricting visits to sick people. And saying you can't visit your mother or father even though they're dying in the ICU. And then we'll get back to a few points around the rationing of resources, as I mentioned. There's major ethical questions which arise around the use of experimental therapies and the research around experimental therapies. And then there's ethical therapies which arise from being a health worker and putting yourself at risk or refusing to put yourself at risk. Okay, so let's just go through them one at a time. So we know that you have to disclose, legally you have to disclose, sorry, that's not a COVID cough. You have to disclose it to the government. It's a notifiable disease. So there's a legal responsibility to do that. We trust that the government is keeping the data confidential and that those databases are protected, but you have to do that. We do know that the reason to notify this is that there's a risk of spread to vulnerable people, and that may override the right to confidentiality of a person in certain instances. And we've learned a lot from the HIV epidemic, for example, where there was a big question: should you disclose to the spouse or to the partner of this individual when the individual refuses? And there were a lot of ethical discussion around that, and the answer was clear-cut, that you initially offer the individual the option to disclose it themselves, and if they cannot disclose it themselves, as a doctor, you are legally bound to inform the spouse or the partner that this person has HIV disease. And similarly, this person would be required to notify these contacts and people around them. And if he does not notify his contacts and people around them, as a doctor, it should be your responsibility to do that. But it's practically almost impossible in South Africa. The person would have to self-identify his contacts. And this is it's not like HIV where it's a long-term disease. The person is coming for follow-up. This is an acute disease. So the question arises, if someone is in ICU then and they can't notify their family that they've got COVID-19, should you tell their family that they're admitted for COVID-19? And I think in that case, it would be necessary, because some of those family members would be contacts themselves, and some of those family members may need to notify other people who are contacts so that they can take the measures which are required. Okay. And obviously, if the patient refuses to isolate and refuses to stay, then you may actually need to notify the authorities that this person refuses to isolate and would need to be legally made to isolate to protect others in the society. Okay. Restricting access to hospitals is a big problem. Obviously, it potentially protects visitors and patients. So it protects the visitors from being exposed to the COVID ward, to the patients in the COVID ward, to the healthcare workers, and it protects patients in non-COVID areas from being exposed to people coming from outside who may bring COVID-19 into the hospital. Obviously, you have to weigh the rights of the patient against this. The patient has a right to transparency. The family has the right to know what's going on. And many families have told us, you know, you could be doing anything there in the hospital. We have no idea. You could be killing our father. We have no idea. We don't have any idea, especially in patients on a ventilator who are unable to communicate, who don't have phones of their own. We know that part of having dignity in death, especially from a Muslim perspective, is having those closest to you around you, reading Yasin, encouraging you to take Shahada. So we know those type of things are big issues for families. And whether that outweighs, whether the risk of infection outweighs those rights of a family is a very difficult question. I think as Muslim doctors, where possible, we should try and facilitate that for our Muslim patients and for other patients as well. Allow them a death with dignity. Try and use your own means of communication to let the family see them, sometimes to say goodbye, to speak to them. These are really heart-wrenching questions, really difficult things to deal with. But it is something that we're going to have to deal with. It's one of the reasons, actually, as Fatima mentioned earlier, why patients don't want to go into hospital, especially patients who are elderly and who feel, you know, they have a fatalistic view of life. I'm going to die. It's my time. I'd rather just stay at home and die at home. At least my family will be around me. And that's not it's not a frivolous concern. It's a really valid concern that we need to take into account around these patients. Very easy for us to say this patients be stupid. If they went to hospital, they could survive. But we can't guarantee that for sure. And certainly that ability to die with their family around them may be the most important thing for them in their life. It may be what they've lived for their entire life. So it's difficult for you to make that decision for the patient. It's easy to say this patient is refusing hospital care. We should, just let them die at home and they don't deserve anything else. But to make that judgment call for that patient is a very difficult one. One of the things about hospitals is they should have a defined policy, and I firmly believe it shouldn't be absolute. There should be circumstances, for example, in patients who are not COVID positive in a separate ICU, where the family can come and visit them in PPE or for a short period through a window to be able to see the patient and give them some encouragement. And it may obviously depend on the stage of the pandemic. There's no rationale to completely close hospitals when you have a few cases in the community, but it may be a very important act when you have a surge. Okay, and then the hospitals then have a responsibility to facilitate additional online contact. They should have free Wi-Fi for all patients. They should make sure that it's possible for patients to contact their family freely and easily, and that staff should be made responsible for contacting families and giving them updates every day. And doctors are very bad at doing this. I can speak for myself and my colleagues in almost every ICU that I work at. Doctors don't phone families, patients. And looking at the groups that we're on, we have so many requests every day for, does somebody know somebody at Milpark, Joburg, and Helen Joseph, Leratong, wherever? We need information about our mother who was admitted a week ago and is in ICU and we don't know what's going on. So that's really unacceptable. There needs, I know doctors are overrun and overworked and really in difficult situations, but the hospital probably needs to employ a specific person just to do that job at this particular time. Okay. Now let's get to rationing resources. And when I'm talking about resources, it's across the board. There's probably resources that are left out here, but we're looking at staff, PPE, we're looking at rationing tests, rationing beds. We know we're rationing time. We're admitting patients for shorter and shorter periods to get them out so somebody else can come in. And then inevitably, once vaccines are available, there's almost certainly going to be a process of rationing vaccines. It's very unlikely that we'll get 8 billion vaccines all on the same day for everybody. There's going to be a process which will have to be followed. And obviously countries like the United States and Europe are suggesting that the process is those who can pay should get it first. And obviously that will be debated and widely contested when the time comes. So this is one of the situations, one of the proposed situations, or just an illustration of what can happen as the surge develops. So normally when you have normal capacity and just a slight increase, maybe a 20% increase in the amount of patients that you have, you can still cope. You increase the number of staff, you produce good quality care. But as the burden increases, there's almost no doubt that the quality of care will decline. So the numbers of patients will overwhelm the system, and the quality of care will decline. And eventually, hello? I think somebody's mic is not muted. Eventually, we'll reach a situation where it's possible for the entire system to collapse because there's so many patients and such a breakdown in the availability of resources. And that's very possible in COVID-19 because not only does it cause increased numbers of patients with a static staffing system, it actually affects the staff. So the number of staff members progressively decline as more and more. And certainly they saw this in Italy, they saw this in New York, they saw this in the Western Cape, where people who are actually at the forefront of helping others in this crisis were affected and then knocked out. And that has a knock-on effect. It has an exponential effect in terms of your ability to care for other patients. Okay, so then that leaves you to the how you should allocate resources and what type of priority setting you should use. This is the WHO guideline around COVID-19 and the different principles which they set out in terms of how you should apply them. And they said you should aim for equality, and there should be good reasons if you're going to prioritize. And at the bottom you can see they said you can prioritize people with good reasons. And one of the groups that you should prioritize is healthcare workers, as I mentioned, because of that knock-on effect, because of that exponential effect of healthcare workers being affected. So if you have 2 beds, if you have 2 beds and 3 patients, and one of them is a healthcare worker, you should prioritize that healthcare worker for getting that bed. Obviously, this is there's a slippery slope there, and I'll get to that, how you do that without running into some ethical problems itself. You're obviously then going to use the utilitarian concept of having the best overall outcome, maximizing the number of patients you can help and the number of quality of life years you can gain. And then you're also going to prioritize those who are worst off. So the WHO clearly says you should prioritize those who are the most vulnerable, because people who are less vulnerable may have other options, and prioritize those who are helped with tasking others like healthcare workers. And that's from the WHO. These are some of the advantages and disadvantages from the Emmanuel paper. But going back to the WHO, when you're applying these principles, they say you have to apply these principles in a way which is transparent, inclusive, and consistent. So these are important things. And this is why you need a written policy or a dedicated policy, so it can be open for people to criticize. It can be open to change. It can be inclusive, so that people have ability to comment on it, to say what they want to upfront. And then it should be consistent. If it's written down and you can refer to it again and again, you can apply it consistently. We know in South Africa, some of the issues which are going to affect us is we have major inequality. We have big gaps in quality control. And I mentioned some of this before. There's an extremely low level of integrity in our society, from administrators, politicians, right down to individuals. You can't even trust patients, actually. When we do general screening in our dialysis unit, for example, many patients will hide their symptoms, knowing full well that it has an implication for infection control in the unit. And many of them we will discover 2 or 3 or 4 days later, as they become sicker, that they were symptomatic for a few days before and never disclose it. And by that time, you've got other people who are infected in the dialysis unit. And it's common, and patients don't disclose it because if they're going to disclose it in a dialysis unit, for example, it means that their whole routine changes. They can't dialyze immediately. They have to come back a little later to dialyze in the PUI shift, or they may need to skip dialysis today and come back tomorrow. They may have to go for a COVID test and do 1 or 2 blood tests, which incur some costs for them. So there are valid reasons, or reasons why patients will hide their symptoms, so that and also human nature is such that they'll think to themselves, it's just a flu. My nose is just running a little bit. I can't have COVID. I didn't really have any contact. But they're required to report these symptoms, and they don't. Okay. This is another system which has been used in renal medicine in South Africa and around the world, and it's applied by the NICE Guidelines Committee in the UK. NICE is a guidelines committee which sets out guidelines for the NHS, which are based on this system of accountability for reasonableness. And the 4 elements are that it must be fully transparent, as similar to the WHO guidelines. It must be relevant and reasonable. So that means you don't necessarily have to have clear-cut evidence-based medicine. And it's going to be the case with COVID-19. We don't have clear-cut evidence for everything, but it should be reasonable based on the current evidence that's available, and it should be relevant to the society that you're practicing it in. You can't practice a type of system which would work in New York or London, which won't work in South Africa. And that was one of the arguments against the lockdown in South Africa, that while a lockdown is reasonable for a country like Denmark or Australia, which can lock down every 5 minutes and will have some economic effects, but they'll survive it. Whereas you can't do that in South Africa, where a lockdown will be unreasonable economically. So it needs to have those, and you can agree on what's reasonable and what's unreasonable. It should be revisable, so you should be able to change your mind after looking at a change in evidence, after looking at the effects of a certain, or the unintended consequences of a certain priority setting process. You may be able to revise it. It can't be set in stone forever. You shouldn't say, no, we must be consistent this week. So because we jeopardized those patients last week, we have to jeopardize the patients next week as well. If something has changed, you should be able to change the system so you can save the most lives. And then obviously it should be enforceable. You can't have a system which is completely unenforceable, where everybody will do their own thing, or which has set such obstacles in front of people that it's unenforceable. Okay. These are the recommendations from the NEJM paper, the Emmanuel paper, and it's similar to what I've said before. They go for utilitarian consequentialist approach, where you try and maximize the benefit. You save the most lives, the most quality adjusted life years. So that's important. Quality adjusted life years means that if an 89-year-old comes in and you can save his life, you would rather save the life of a 35-year-old, because the number of years, quality adjusted life years that you're going to get from the 35-year-old is likely to be much more. So when you look at it that way, you're going to prioritize young people over old people, people who have less comorbidities over those who have more comorbidities. You're going to they specifically mentioned prioritizing healthcare workers for tests, for beds, and for ventilators, because if you lose healthcare workers, it compounds the problem. Also, prioritizing healthcare workers for tests means that there's better infection control in hospital settings or in healthcare facilities. So that's very important. And most labs have recognized that as healthcare workers, you can get urgent blood tests with or urgent swabs with turnovers within a day, if not a few hours. If all else is equal, and this is similar to what the WHO and others are saying, you need to then develop some type of random allocation system, which should be independent. That means you should have a system where you put 3 names into a hat and pull the name out of the person that benefits. So if you have a scoring system, or you have some type of system where the ages are equivalent, where the comorbidities are equivalent, where they don't have any other priority settings, and there's only one bed available, you should have a system where you put it into the hat rather than using a first come first serve system. A first come first serve system is not the best system, because it may jeopardize people who live further away from the hospital, who have less resources, who are poorer. So the idea is then to use, and through no fault of their own. So the idea is then to use a random allocation system. Again, criteria and guidelines should be revised and applied. You need to, they suggest that you prioritize those who volunteer for research. So similarly, this would be rewarding people and encouraging people to come forward for research. It's not an easy thing for people to come forward for research for vaccine trials and so forth and so on. And by prioritizing them, you obviously make those people much more likely to come forward for trials, which then provide information which every one of us can use. Okay, one of the other things which is very important, which people are forgetting, is that you can't forget every other condition which exists. You have to allocate resources to COVID-19 and other medical conditions appropriately. You can't say, okay, we've got COVID-19, it's a major problem for the next 2 months. Everybody with renal failure, with cardiac failure, with chronic lung disease can die in the meanwhile. We'll just dedicate our hospitals completely to COVID-19. You can't do that. You have to then look at setting some type of system in place which allows patients with other conditions to have access to care. But likely you're going to have to ration access to care for those patients as well. And if you look at mortality data from the US, from Europe, the number of additional deaths, there was a significant number of additional deaths in April, May, June, in almost all of the countries in the Northern Hemisphere. And some of those deaths were directly attributable or explainable by COVID-19 infection, but others were probably deaths caused by other conditions which were not getting adequate treatment and not getting to hospital on time or not being able to get a bed. So there was unexplained deaths which were beyond COVID-19 as well. Okay, this is what I talked about earlier about running into a slippery slope with prioritizing healthcare workers and others. If you're going to have a prioritizing strategy, you need to have a team which makes a decision. It can't be a decision where you will be open to the accusation that doctors are protecting themselves by making sure that they prioritize healthcare workers. They're taking the bed for themselves and my mother didn't get a bed. You need to have a team and a consistent process where it's written down what the priorities, the prioritization mechanism is going to be. It should compose of some doctors, but you should have a medical ethicist, and you may actually need an administrator or two in that group to be able to assist with the decision. So it should be a team, and every hospital should have one. And for those home-based groups as well, where probably we're going to end up having to rationalize or ration oxygen concentrators, you probably need a team of people who will make the decision independently. Remember that life and death always remains in Allah subhanahu wa ta'ala's hands. You will have to individualize some of these things based on emergent situations, and you have to have some degree of flexibility built into your priority setting. Remember that family dynamics and guilt can be a huge issue. So families can put you under pressure. You can feel very guilty. People may need, and that's why it's important to have a team approach where triaging and priority setting is not done by one person on its own. I mean, some families will feel when they're not taking their father to hospital, they'll phone you and say, my father's 89 years old, he's got COVID-19, he doesn't want to go to hospital, but we want him to go to hospital. Should you then insist they take him to hospital? And the family will have huge guilt around it, that we let our father die. Or one family member will tell the other family member, you let our father die. So those issues can be big problems. And sometimes you need to manage them, you know, by assuaging the guilt of the family. Sometimes if a person is like 95 years old and is in severe respiratory distress and you are certain they'll need a ventilator, it may be the right option to allow them to die with dignity at home. And it's not necessarily the wrong option. So those are the type of decisions individual general practitioners are going to be making probably in the next couple of weeks. Some people feel that if we throw more and more resources at a problem, we can fix it, but many problems are not like that. So COVID-19, we can throw 100,000 ventilators. I'm not sure we'll save every patient in South Africa. It's not the ventilator. There's lots of knowledge which is unknown. And then taking all the resources of a country and throwing it at a problem obviously leaves us with less resources for other things, for food, for housing, and so forth and so on. So we need to then look at how we apply this in the context of COVID-19. And as healthcare professionals, we can't demand that all the resources of the country be put into healthcare to the detriment of other areas of the country. One thing that's important is that you can always comfort the patient and the family, even if treatment is withdrawn. There's always still a duty to care. So if somebody doesn't want to come to hospital, if somebody doesn't qualify for a ventilator or can't get a bed in hospital, doesn't mean you just tell them, look, there's nothing I can do. You just stay at home and now die. So there are things you can do. There's palliative care aspects. You can lessen suffering. You may give some analgesia. You can use low doses of morphine to reduce anxiety. You can help the family to get through it. You can use oxygen sometimes as a palliative mechanism to make the patient feel a bit better as they're dying, if it's available. So many of these things we need to remember. And then obviously we will encourage them to continue to make dua, to have hope in Shifa from Allah subhanahu wa ta'ala, and to have fully yaqeen that the healing comes from Allah subhanahu wa ta'ala. And then also if the person dies, to give them our support and encouragement. And so these are the things you can continue doing even when you can't ventilate or get a bed in hospital. Okay, and then certainly from our perspective, but in general, you need to check your intention repeatedly. Are you proposing a treatment because it will make you money, it will make you famous? Are you withholding a treatment because it's extra work for you? Now, I can't go and give this patient, go to his house and give him steroids because now it's going to make my life a misery. So I'd rather say he doesn't qualify for steroids. So those are the type of things where you need to seriously look at your intention and see what your role is in optimizing the benefit to patients. Okay, let's talk about experimental therapies. They have to go through an appropriate ethics review. Many therapies at the moment are being prescribed which are not registered for these indications. They should be used under something called the MURI framework, which is the monitored emergency use of unregistered and investigational interventions, which means there's a MURI form that should be filled in and submitted, and you should be reporting any adverse effects. I think this is not happening at the moment with COVID-19 because we are certainly overwhelmed. But many medicines are being used off-label in ICUs, in other settings, antivirals, anti-inflammatories, and other things which are being used, which are not registered for COVID-19. But essentially, this should happen. If you are going to do a randomized trial, or if you're going to use a medication which is not registered for this indication, you should get consent. At least you should ask the patient and let them know that you're using this medication, or from their family. One of the problems we have is that there's a rapid rate of change in available evidence. Things change almost every second day. Something that was indicated yesterday is now toxic to the patient, like chloroquine, for example. And then there's a hell of a lot of poor quality evidence which proposes treatments which may or may not work. This goes to everything from toxic medicines to homeopathic or herbal medicines. So there's a lot of data out there which can confuse and obfuscate the picture. This includes anecdotal reports, and this includes reports from social media, which are difficult to verify. So I think one of the things as an individual, you have a responsibility to verify the information that you're getting, to double check it, to ask experts, and then certainly if you think you're going to use it for a particular patient, get consent, explain to them the limitations of the medicine, even if it's a herbal medicine, explain to them the potential side effects of the medication, and then you need to monitor that patient. Okay, I mentioned healthcare workers. There's a big problem with adequate PPE, but we should be making sure that particularly healthcare workers and people on the front line have adequate PPE. There's a big issue with refusal to work, people going on strike because they don't have adequate PPE. So there's a fine line between your duty to care and the responsibility of the system to look after you. And I think we're sort of crossing over that line, and some of the issues will only probably become evident in months to come. In the UK, in Europe, in Italy, many people had poor access to PPE, and they made for themselves inadequate PPE, which they then used, and they got infected. Those people will say, look, they did the morally right thing, but it had a detrimental consequence on themselves. They were sacrificial lambs. But the question is, at what level do you stop being a sacrificial lamb and need to look after your own well-being? And there's no moral answer to that. Society can't hold you responsible for not being a martyr or a sacrificial lamb and going in with no PPE. But at the same time, you have a responsibility at some level to society. You have a contact with society to provide care, and where that line is blurry. I suspect many of us as individuals have our own ideas as to how far they're willing to go for a patient with COVID-19, and that line may shift depending on whether that patient is a family member or not. Okay, you need to then prioritize and plan how you use your healthcare workers. We know that some healthcare workers, for example, may have chronic conditions, they're elderly. You may need to put those healthcare workers in areas where there's no COVID-19 patients, or it's possible that elderly general practitioners should say to their colleagues down the road, look, I will look after all the chronic conditions, you look after all the COVID-19 patients, we'll split the cost of the PPE. And so that you don't have to bear the full burden of the PPE, whereas I don't have to bear the full risk of having to treat these patients. So those are the type of agreements we should be looking at and making within our small circles. If you have a 70-year-old GP who needs to work for financial reasons, and the reality, there are many like that out there, who can't stop working because if they stop working, their quality of life, or they haven't had financial planning, which has left them in a state where they can stop working. They have to work, and if they continue working, they put themselves at serious risk of severe infection at this time. So they may need to change the priority and the way they work, move to telemedicine and make arrangements with their younger colleagues, sometimes get a locum, sometimes arrange with a colleague down the road. So I think we need to be thinking along those lines. We need to be thinking originally to make sure that we protect our health workers. Whether chemoprophylaxis works is not clear. It probably doesn't. Most of the data suggests that it doesn't. The Indian authorities produced a survey-based results which suggested that hydroxychloroquine reduces the risk in their group of patients, but it's not clear-cut certainly. Okay. These are the guiding values for healthcare workers as published by the National Academy of Medicine in the US in terms of dealing with patients in general, not specifically during a pandemic. But you can see some of the things that come up are similar to what we've discussed before. And that's it. I don't know if you guys can hear me. I think maybe I've been talking to myself for the past hour or so. But it's quite entertaining.
It's a pity you couldn't hear the people laughing at your jokes, Shaib. Jazakallah khair for that. A lot of food for thought. A lot of work still needs to be done, and some very interesting points being made by Dr. Shaib. Perhaps if you look at the chat, Shaib, on the side, there's a few questions that have come through. Dr. A.K. Desai says, like in HIV, is pre-test counseling necessary in COVID-19?
So technically it is, like in any disease. In fact, pre-test counseling is necessary for every single test you do, even if it's a full blood count. The patient should know what to expect if the results are abnormal. But you know, in medicine, we sort of find a balance between what we can do and what we should do. So in reality, most people will know what the implications are of a positive test. And people, when they come to you and you're going to do a test, you should at least tell them if the test is positive, it will mean X, Y, and Z. In fact, if you're doing a test for an indication, the patient should already be isolating. It's as compared to if you're doing a test for surveillance or for screening or for admission to hospital. But even when you're doing that, if you're doing a test for admission to hospital, you should be saying, we're doing this test to make sure it's safe to admit you to hospital. But if it's positive, it means you can't be admitted and you will have to be isolated. At the very least, you should be telling the patient that. Obviously, we actually can't tell the patient much more because we don't know how that individual patient is going to react, how sick they're going to be. But many patients are aware of that they know that the disease is widely variable. And I think most of the time when I'm testing a patient, the ones in our dialysis unit, the ones we see in the hospital, I'm telling them, especially if they have mild symptoms, that most patients are doing well. Don't panic. You will have to isolate and we will look after you. So those are the type of things you need to tell them. I think the second thing is you must follow up. So we're having patients where somebody does a test and nobody follows up the patient. Then the patient is looking for information on general family groups, and in, you know, they're putting information onto NGO groups and other groups looking for information. Surely that person should be linked to a general practitioner or doctor who requested the test, and they should be directing their questions at that person, you know.
Yeah, I think that leads us on to Maud Mullah's comment, where he says that he agrees that it's Islamic duty to phone family members if you're looking after patients at least once every 24 hours, irrespective of whether the patient is a Muslim patient or a non-Muslim patient or whatever race group is from. The problem is the time. It's the right thing to do, and I think the best thing to do is what he suggests, is that you nominate one family member which you communicate with. And I think that's sort of general advice for any time, any part of your practice, not just during COVID times.
Look, I agree. I think in our practice, our rooms are practically closed. We're only doing telemedicine. So even if we tell our secretary, please phone these patients and tell them that their father is okay or whatever, and then we'll speak to them tomorrow, at least they're getting some feedback. If you can't do it yourself, if you're fully overwhelmed or whatever, at least tell your secretary to give them a message or offer them the option to call you at a specific time. In fact, I find it easier. Now, many of my colleagues don't, but normally I will say, tell the patients, this patient can phone me at this time, and you leave an hour of the day, then you know they will phone you. You don't have to remember to phone them. But you're right, you need to nominate one person. Okay, you can't have 10 family members phoning you to ask you about the same information for the same patient. It's not fair on you.
There's a comment from Hanifa Jeffers. She says, thank you, doctor. Appreciate your compassion and hope your input could be further than this conference. So Shoaib, unfortunately, his influence, we try and get him into all spheres. So we're quite active on all the groups, all the guideline committees. I think there's a couple of questions for Dr. Fatima. Unfortunately, she's left. Dr. Bulbulia, I'll forward the questions to Fatima and I'll try and get back to you.
Fatima, if people want, I can help with some of those questions.
Okay. All right. Yeah, so Shoaib, the question then is that the Decazone dose is a BD dose. It's quite a high dose. What about mental delirium? And then obviously what we mentioned before about the GIT side effects.
So Bashir is right in terms of the BD dosing of Decadron. It's not really necessary. But Decadron's got a very long half-life. It's just historical that people use Decadron BD. I don't know why, whether it makes them feel better, whether they think they're spreading out the side effects. It doesn't really make a difference. It's been shown in studies that you can give the entire cumulative dose at one time in a day. So you could do that. It is a high dose. And Fatima is right in terms of, so for most other indications, historically, dexamethasone has been used at much higher doses than the Recovery trial. And I think many people were surprised at the dose that they use in the Recovery trial, which is like 6 milligrams. Yeah. Whereas we had a few patients with intracranial bleeding or with raised intracranial pressure or with sepsis, we sometimes use like 16 to 20 milligrams a day, as Fatima was saying. Yeah. So she's then extrapolating that evidence from a previous trial showing that a higher dose has an effect and may have a better effect than the current effect, which seems to be a moderate effect. There's quite a large number of people to treat, as she mentioned. So, so the rationale is that if you use a higher dose, you may save more lives. It's not clear yet. And then the GI side effects are significant. Certainly, we have seen delirium. I know she said that they haven't seen a lot. Maybe it's not. You're not going to see a lot if the patients are ventilated and sedated. But in awake patients in a ward setting, we have seen it. A bit of delirium, a bit of confusion from the dexamethasone. And if you use higher doses, certainly you will get that. In my experience, it's mostly with people who may have some type of underlying neuropsychiatric abnormality, which has been undiagnosed or which has been treated even. But we do sometimes see it in people with no previous psychiatric or other history where they just become a bit confused and frankly psychotic sometimes.
Okay, yeah, I think that's quite an important aspect. And perhaps as our next Webima, we should try and do something on the mental health aspects of the COVID in terms of healthcare workers and perhaps also as what knowledge we need to have to help our patients. Bashir also talks about the ferritin levels as a useful marker for your inflammatory response and its down regulation.
Yeah, absolutely. It's a fantastic marker. The problem is it's like 800 rands a day to do a ferritin. And the CR costs 30 rands a day and gives you the exact same information, to be honest. So we know that goes in many acute inflammatory states. It seems to be much higher in this sort of condition, which makes people that there may be an element of a macrophage activating system syndrome in these patients. But it's not going to independently change your management on a daily basis. So we suggest where there's a tiebreaker. So for example, if you're not sure whether you need to admit a patient, that you do the ferritin, if it's really very high, together with a high CRP, high D-dimers, you would rather admit the patient, even if they're not looking very sick to you, but they're sort of borderline. So I would suggest that things like a chest X-ray, a ferritin, those type of things may be useful to give you information as to whether you need to admit this patient or it's safe to treat them at home. Or whether the diagnosis could be incorrect. So we know that a COVID swab can be negative even in a patient who has COVID-19. So if you convince the patient has COVID-19 based on the X-ray, the clinical features, but the swab comes back negative, and then the ferritin comes back at 4,000, I would treat the patient as COVID-19 and repeat the swab in 48 hours. So I think the ferritin has a use in that context, but on a daily monitoring level, it does come down as the inflammation comes down, but so does the CRP. I think that it's cheaper to just use the CRP.
Okay. And then Rukia Vaura says, Dr. Wari, thanks for the valuable input on the ethics. She's especially grateful for the compassion factor because of the huge stigma and fear and the other mental issues we're seeing around this thing and the need to comfort patients and their families.
I mean, that's true.
Yeah. I think quite an interesting thing in terms of resource allocation, which we faced with directly if you're sitting on any of the panels in the community groups like SUM or the Greenside Oxygen group. Our first sort of level of interaction with these resource allocations is with the oxygen machines. Because if your community owns about 10 machines, and at some point you're going to have to start now rationing them, and how we base it. Do we base it on whether it's a Muslim patient in the community? Do we base it on the guys? So we're going to have to really sort of work these things out. And I really like the idea that we have an independent panel that can look at these things.
No, certainly, because if you do it in your own community, chances are your mother lives in your own community, your wife lives in your own community. And then it's going to become a very difficult decision, and you open yourself to accusation when you say you're part of the committee, your mother got a machine, and X down the road didn't get a machine. So to protect yourself as an individual, also to ensure transparency and fairness, there should be a system, and it should be done by more than one people, a committee. And as I said, I would include clinicians, but you may want to include someone from the community, maybe even one of the members of the ulama from the community to give you some spiritual guidance. Also to give you some comfort, because these can be difficult decisions to make, to be honest, and give one with a sense of guilt when they're unable to help people.
And then AKP just wants some advice on these COVID positive patients. The few I've seen also with a lot of paresthesia. They complain quite a bit, especially in the hands and the fingers. What can we use possibly for the paresthesia?
So I think one of the things you need to look at with the paresthesia is, are these patients getting paresthesia because they're hyperventilating? So, hyperventilation and blowing of CO2 and causing alkalemia can cause a paresthesia. Certainly, you can be making yourself alkalotic appropriately. So one of the things people don't realize is you can maintain your sets if you breathe fast enough, even with lung disease. But if you do a blood gas, you will see that patient has a high, what we call an AADO2. That means the alveolar air difference in oxygen. And one of the markers of that will be the carbon dioxide is very low. It means the patient is working hard to get oxygenation into their body, and by working hard, they're blowing off CO2. And then if you blow off CO2, I'm sure you've seen it, Zahir, the pH can go up to 7.5.
Yeah, we've seen quite a few of the patients, 7.5, 7.52, yeah.
So then the ionized calcium drops and the person gets paresthesias in their hands, in their mouth, feel very weak. So it can be hyperventilation. The problem is you can't stop that hyperventilation in that patient sometimes because they needed to oxygenate. The answer for those patients is to give them oxygen. So someone needs to count the respiratory rate and see, is that person working hard, breathing faster, and then give them oxygen. The respiratory rate will come down, the CO2 will go up, and the paresthesias will disappear. Obviously, there may be other mechanisms of paresthesia development, including neurological mechanisms, and we're still finding out a lot about the neurological impact of COVID-19. How you treat those, obviously, you may treat it like how you treat paresthesias generally, which will include things like pregabalin or gabapentin, amitriptyline. I wouldn't recommend amitriptyline because of its anticholinergic effects. But I think maybe you can use Lyrica or Neurontin at a very low dose. But I think the first step is to make sure there isn't the patient isn't blowing off CO2 to allow them to oxygenate. Obviously, you can do it from pure anxiety. So even if your CO2 and your oxygenation is normal, people may just be anxious, and then they're breathing fine, and they worry about their breathing. Oh, I don't feel right, and then they take like 20 deep breaths, and then they develop paresthesia. It's possible. In fact, that's one of the mechanisms of the dizziness that people complain of when they breathe deeply recurrently. It's the drop in the calcium, which can also drop your blood pressure a bit, as well as if you're breathing deeply recurrently, there's almost a negative effect on your cardiac circulation, like almost a Valsalva effect recurrently. So it increases the thoracic pressure. So you really want to then calm that person down and then see what their sets do, count their respiratory rate, and decide whether they need oxygen.
It's interesting. Some of the patients who are totally asymptomatic start after 2 or 3 days at home, start getting the paresthesia, thinking it's symptoms, purely because they're hyperventilating because of the anxiety. We've seen a few of those patients too. There was a clip that recommended the use of budesonide early on. I'm not sure about this clip itself. Dr. Saluji, perhaps put it on one of the groups and we can maybe discuss it. Dr. Mohammed is talking about Quran recordings for patients in high care, not sure of ICU. Very interesting. There's I've seen a few where the people do video calls, or they basically, before admitting the patient, discuss with the patient and the family what would they like that patient to do as they get critically ill. Many patients opt for having Quran Tilawat recordings recited at the bedside, even if they're intubated or in extremis. Some patients opt for a video call where the family members recite for them. In Canada, they've used this quite successfully in their ICUs. I think we should maybe think about doing this in our ICUs too.
So I mean, in the UK and elsewhere, they have a policy where every admission is asked for an advance directive. That means they ask them, what do you want if things become bad? And then they together with the patient and the family, and obviously the priority setting milieu which they have in that hospital, they will determine, first of all, a ceiling of care, almost right at the beginning. So that means if an 89-year-old comes in short of breath with multiple comorbidities, they will tell him, after discussing with him, that we're unlikely to offer you a place in ICU. In fact, you won't get a bed in ICU. You will only get whatever we can offer in the ward. And that includes this, nasal cannula, oxygen, steroids, this. And then also, if things become very bad, what do you want? Do you want us to discharge you home? Do you want us to contact your family on video call? What do you want? So then they offer the patients that option. So I think those are some of the things. I'm not sure about the ceiling of care in South Africa because we don't have very well developed protocols. In the UK, they've had that for years. So many patients have advanced directives, which they've done many years before. That I don't want to go to ICU. I don't want to be on a ventilator. I don't ever want to be dialyzed. But in South Africa, many people have never thought of that. So it's difficult to impose that decision on them in like 5 minutes when they come into the hospital. But certainly you could ask a patient repeatedly, if things become bad, what do you want? Do you want to go home? Do you want to go to ICU? Do you want to have a WhatsApp call with your family? Should we be around for you? Those sort of things. So I think those type of questions with patients, all patients, not just Muslim patients, probably very important.
Okay. The last question is unfortunately running out of time. Our last question is from Dr. Zahira Bodiat. She wants to know, during COVID especially, we're finding ourselves as healthcare workers and doctors being put in a situation where we are treating a lot of our immediate and extended families and friends, which is generally sort of frowned upon in terms of sort of objectivity. But unfortunately, we're being placed into these situations. Any advice ethically and also just from a practical point of view when you have to deal with now your immediate and extended families in these COVID times?
Yeah, it's very difficult, obviously, and you're forced to do it because there is a shortage of available resources. I think obviously where it's going to be a major emotional impact for you, and it's going to affect your decision making, which is very likely in your sort of immediate family, your mother, father, brothers, sisters, and kids. You should probably contact a respected colleague and ask them to take over. And then you should do the similar for colleagues who contact you and ask you to take over care, you know, so that you make a rational decision around decision making. Also, sometimes very difficult for you to tell your own mother or father that you must go to hospital, you know, since who's the father and who's the mother? That's the question you get. Whereas the same, at the same time, if one of your colleagues comes and says, Auntie X, you must go to the hospital, it will be much more likely to be expected, you know, accepted. So I think if it's somebody really close to you, I would recommend that you delegate it to one of your colleagues that you trust and that you respect, and that also has access to the person. If it's somebody who's sort of a bit more distant, it'll be harder for you to do that, but it's going to be inevitable, I agree.
Yeah. All right, Jazakallah khair. That brings us to the end of our very interesting discussion. I just like to thank everybody, all the participants for taking time out, missing your lunch, your Sunday lunch. Jazakumullah ahsanul jaza. Allah reward you for coming and supporting us and listening to the interesting speakers. I'd like to thank all the speakers. Really, we had an excellent panel. Dr. Fatima, Naima, Shuaib. It was really, really enlightening. A lot of questions, a lot of comments are coming through on the other social media platforms that really appreciated the talks. A lot of suggestions are coming through in terms of future webinars. Just a reminder, you'll get a questionnaire after this meeting that will be posted to all the participants. Please try and fill in the questionnaire. It really helps us with the planning going forward. And then just to remember, the take-home lesson from all of this is that the network has really made a big difference. And so I'd like to encourage everybody to be part of a network. I think as IMASA, we're also available as a network of many of you who are not members. Think about signing up. Many of you who are members and have signed up but are not active, start getting involved in the branches, start getting involved in the multiple projects within your profession, in your extended profession. Really, there is so much more we can do as a society and as a community, and it's time for us to step up to the plate. We make dua, Allah Ta'ala keep you all safe, keep you all, give total shifa to all the people who are suffering from COVID-19 and other medical illnesses, and grant afiyah to all the families and the people that are going through this very, very trying time. We close the meeting with wal asr. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر.